Good morning and welcome everyone to the first. Oh, I've got the. Am I wrong?
It's the second meeting. Sorry. Yeah, it's okay, person.
Right. Okay. Good morning and welcome to the second meeting in 2013 of the Health and Sport Committee. And as usual, at this point, can I remind those who are present to switch off mobile phones and Blackberries and other wireless devices, as they often can interfere with the sound system. First item here on our agenda today is to take evidence from the Scottish Government to begin our scoping exercise ahead of our inquiry into health inequalities. And can I give a warm welcome to the committee to Derek Feeley, Director General, Health and Social Care, and Sir Harry Burns, Chief Medical Officer, Scottish Government. And I invite them, both of them, to make opening remarks, and I presume that you've agreed who will proceed first. Mr. Feeley. Good.
I'll start, Convener, if it's okay with you. I think you'll probably find as we go through the evidence session this morning, I will defer to Harry on this subject more than I would, I think, on virtually any other. When you have someone who's with his expertise sitting alongside you, it's often best just to bow to that. First thing I think we would want to say is to very much welcome the committee's interest in this issue. It's one of the most significant issues facing us. The recent Audit Scotland report on health inequalities in Scotland started by stating tackling health inequalities is challenging, and I think that's an understatement. It's probably the most complex problem we face. There's no simple solution. And when Harry and I went to the Public Audit Committee to give evidence on the Audit Scotland report, we did two things. Firstly, we welcomed the spotlight that Audit Scotland were shining on this issue. But second, we were keen to make the point that while the Auditor General's report was helpful in terms of its analysis of the challenge, we felt its recommendations were too narrowly drawn. This is something that required a broader response than was suggested in the Auditor General's report. And there have been numerous reviews of the evidence on what policies and interventions you should pursue to reduce health inequalities. I think the best summary of that is in this document, which I would commend to the committee, and I'll leave for the clerks. It's written in 2007 to inform the Scottish Government's Task Force on Health Inequalities, written by Sally McIntyre from Glasgow University. It's called Inequalities in Health in Scotland. What are they and what can we do about them? And although it was published in 2007, I think many of its recommendations remain valid. And they were reinforced by a recent World Health Organization report, which looked at the social determinants of health and made three broad recommendations. You need to do three things, WHO said. Firstly, measure and understand the problem. Second, improve people's daily living conditions. And thirdly, tackle the inequitable distribution of money, power and resources. And on the first of those, I think we're actually relatively well placed in Scotland. We've got a range of indicators that monitor progress on reducing health inequalities. We published the latest suite of those in October 2012, and we do so annually. And there is no doubt that health services need to play an important role in tackling health inequalities, and that's why the work we've done on some of the big public health challenges, the smoking ban in public places, the work we're trying to do now on alcohol, is really important. It's also really important that NHS initiatives like Keep Well, the targeted smoking cessation services that we've got, our new Detect Cancer Early programme, all really important contributors to this. But I think the conclusion that Harry and I have reached, and Harry will speak for himself in a moment, is that these are all necessary but unlikely to be sufficient. On its own, the NHS can't tackle the whole range of daily living conditions that WHO talk about, or the broader social inequities. And so we've been doing some work to try and recognise the breadth of the challenge. We've got work underway with COSLA to try and enhance the contribution that community planning can make. We're about to start a significant piece of collaborative working around early years, which will go right across the public services, aimed at reducing infant mortality, improving attachment and readiness to learn. It's a really important piece of work and I think potential to make a big contribution in the health inequalities area. And And as the committee will know, we've recently reconstituted the Ministerial Task Force on Health Inequalities. It's had one meeting, it meets again in early February, and it plans to publish a report in the summer of 2013. And I'll pass over to Harry to add anything he wishes to add.
Yeah. I think it's really important not to see inequalities in health as an isolated phenomenon. If you look at the map in Scotland and you shade in the areas with the worst inequality in health, you might be looking at the areas with the worst crime rates, with the poorest educational attainment rates, with the poorest environmental conditions and so on. Inequalities in health are just a manifestation of inequality across the whole of society. And to target inequalities in health without trying to understand what the drivers are for adverse outcomes across all these domains is missing the point. The same kind of thing that causes poor educational attainment in children, that causes an increased propensity to offend, that causes an increased propensity to addictive behaviour in later life, leads ultimately to failure in the jobs market, leads to increased poverty, and you begin a cycle again of intergenerational failure. And the outcome of 25 years worth of interest on my part, starting off as a surgeon in the East End of Glasgow, led us very much to the conclusion that the basic problem lay in early years. It's not the only explanation by any means, but you will not fix this problem without changing the living conditions and the conditions in which very young children are nurtured and grow. Because all the evidence is that adverse and chaotic environments in childhood lead to a number of problems that these children will face later on in life. Children who experience adverse environments, there are a whole range of biological consequences that lead on to behavioural consequences. Children who experience adverse events in early life are far more likely to have mental health problems, far less likely to succeed at school, and you begin the whole generational cycle of failure in a number of domains of living. There are things that we can do not just for children but later on in life that can ameliorate the problems of early life, but unless we break the cycle, the intergenerational cycle, by radically changing conditions of nurture and attachment and support for babies and their families, then we're not going to be as effective as we possibly can be, which is why we've started off with this major effort in the Early Years Collaborative. A whole range of other things that we can do, and we've, as Derek has said, we've started work with COSLA, with local authorities and so on, in trying to change life in ways that reduce offending, that reduce reoffending, that improve educational attainment. Active labour market programmes which are aimed not just at getting young people off unemployment, but are actively concerned with enhancing their skills for living and enhancing their skills for participating in social in the social environment much more effectively. And interventions aimed at supporting the elderly to be independent. All of these things will help inequalities in health, but they'll also help other types of inequality that we see in society. So it would be a mistake for any part of society to think that inequalities in health is just an issue for the health service. It's an issue for the whole of society, just as inequality in offending and inequality in work and so on is an issue for the whole of society. And it's, unless we understand that, we're going to carry on. The graph that shows how inequality in health has been widening as measured by life expectancy. We've looked at trends in life expectancy in 6 and Western European countries going back 160 years. For most of that 160 years, Scotland has been pretty much at the average life expectancy of Western Europe. It's only fallen behind in the last 40 or 50 years. And it's fallen behind in the last 40 or 50 years because the gap between rich and poor has been widening. Affluent people in Scotland have a life expectancy that's better than the Western European average. Poor people, the gap is now, 14, 15 years between extremes in our society. And if poor people had improved their life expectancy at the same rate as they'd been doing up until about the 1950s or 1960s, our average life expectancy would be what it had been for most of the last 150 years, at or slightly better than the Western European average. So there's nothing intrinsically unhealthy about Scotland or the Scots. What has happened over the past 40 or 50 years has been that a large part of our population has failed to improve its health at the same rate as the more affluent in the population. And understanding that is the key to doing something about it.
Gil Patters.
Thanks very much. Good morning, panel. I think what you describe to us is poverty, and I think most informed people accept that poverty and health inequality are the same bedfellows. They go hand in glove with each other. But of course, with the prospect of the working poor and the non-working poor, the prospect very soon that their income will actually be cut. I'm wondering what planning was going in, and what's the government in Scotland's reaction to the prospect of that very thing happening.
I think it would be a mistake to assume that poverty was the cause of this. I mean, my bet is that just about everyone in this room, if you go back a generation or two, certainly my grandfather was very, very poor. He was a miner in West Fife, and with bad lung disease, he didn't work very much. But yet, from very poor communities, people emerge and succeed. What is it that allows some people to succeed when many people fail? That's why we're focused on early years. I won't name him, quite a well-known and very affluent Scot who emerged from humble beginnings, built up a big business empire, and is now actively engaged in philanthropy. And I asked him first time I met him, I said to him, what made you succeed when all your friends probably didn't? And instantly, before we even started, he said, I had a really good family. And this notion of family support, consistent parenting that allows young people to develop a sense of being in control of their lives, allows them to make choices, not to get involved in difficult behaviour, but to succeed at school and see that as a way of emerging. That's the key to all of this. Poverty, I think, is a consequence of much of this, and we've got to tackle that. And it's not for me, I think, to come up with the economic solutions to poverty. But if you get young people attaining at school, if you get them involved in successful activity in the jobs market, then ultimately you will deal with poverty and you will begin to break that cycle. But the key to this is, first and foremost, early years.
The point you make, and have some experience myself in where I was born and where I was raised, etc. But my kind of worry in this regard is that we know what is about to happen, and we know at the same time that, without any doubt, that the working poor will be affected. And the very children that you're talking about and interventions that you would wish to make need resourced. So at the same time as more clientele, if I use that word, are going to be available, at this very same time the resources available to the government to tackle that will also be getting cut. And I'm just wondering, are we in a position to mitigate against that, or I'll be quite frank, are we kidding ourselves on? Can we square the circle with resource, and what even without what's happening or what's about to happen? nevertheless, I believe that the impact on ordinary people in the first place is going to be quite dramatic. And I can only see it going down the way in terms of what's going to happen to families that will push more below the poverty line, and so therefore more work, more intervention will need to take place, in my view.
I mean, I think the first thing that Gil Patterson was looking for there was an assurance that we're building some of this into the planning that we're doing, and I can give you that assurance. So this is the early year, the Inequalities Task Force will have regard to what's happening in welfare reform and beyond into the broader economics. But I think the point that Harry was making is an important one, because it's easy just to get into a kind of slough of despair and think to yourself, well, you know, how are we going to deal with this? I don't see we have any choice. We must tackle health inequalities, and we must do the best we can with the resources that we have to tackle health inequalities. And some of it, there is a kind of cycle, I think, here that you need to break into at some point. I agree with Harry. I think the right place to try and break into it is in the early years. A lot of what we'll try and do in the early years collaborative isn't hugely expensive. It's about doing the evidence-based things reliably well, bringing real improvement signs to the will and enthusiasm that's already out there in the early years community. The environment in which we're trying to make this difference is a very tough one indeed. But I don't think that means that we can just, take a step back and not try.
I come back in, Convener, if you don't mind, just to kind of shift it very slightly when it comes to targeting. And this a picture of a very deprived area, and here we have it here, and a very wealthy area, and here we have it here. But right in between that, there's a massive differential. It's not. If we could see this one area and leave everything else alone, that'd be fine. But my concern or my question is in relation to the people within that sliding framework that I kind of tried to describe. If we were to target excessively into the most needy area, is the likelihood that the people who are just beyond that in a slightly better position, is there a likelihood that they actually might be adversely affected, and so the tables turn in a community, and there are communities, and I know them well, and I can take you to them where a community is in dire need, but just up the road is a slightly better one that's just managing. If we over-target, I suppose what I'm asking the question about universality, is there a danger that we over-target and create a problem in an area that's performing relatively well in comparison to the poorest?
The answer to that is yes, which is why statistically, there is no question the best way to deal with this is a levelling up, bringing all the different, classically we have 5 quintiles that we describe in the population based on socioeconomic classifications and so on. The aim is not to take the best and the worst and make them look the same, because there are people in all these other areas that will suffer significantly. The aim is to try and level up. And that's what will bring the overall picture of Scotland's health back into line with where it should be. So a family in difficulty, regardless of where they live, needs support. And the aim of the Early Years Collaborative, plus all the other interventions that in time we will bring on stream, will aim to help people in difficulty, irrespective of their postcode.
Okay, thanks for that. Thanks, Convener.
Can I take you back just to your introductory remarks and government's response over this period of time, particularly the Scottish Parliament? And It's always been a top priority. And what has went wrong, and why are we in this position, and why have we not identified those problems as we have introduced policy, monitored policy, have had task forces, examined this policy? Why haven't we delivered better over that period of time? So it's quite difficult to make an assumption about what would have happened had successive governments not done what they did. You know, would we be in a significantly worse position than we are today? And I think there are signs that some of the things that a range of governments have done have made a difference. From the big public health measures through to the very targeted things the NHS has been doing, there are some successes along the way. But this is a huge problem. And I think one of the things that we have to do, and I think one of the things that, and Harry might come back to this, one of the things we would ask the committee to help us with is to make some of this stick for the long term, so that, you know, if we could get to a position where we had the whole of Scottish civic society with a clear idea about what it is we were going to try and do about health inequalities, and then committed to sticking with those things for the long term, that I think might make the step change that we need to make. Harry, I don't know whether you want to add anything.
I think the fundamental problem is that we have, as Derek said, we've not stuck at it. We've tended to introduce interventions with 3 years' worth of funding. The interventions maybe have been implemented across too small an area, therefore statistically you're not going to get a big enough change in enough people to be able to demonstrate a statistically significant improvement. And at the end of the 3 years funding, somebody from the local university comes along and said this hasn't made any difference, so you stop it. We're now beginning to see, I mean, Keep Well was a project that aimed to target people based on their postcodes. It was done around GP practices, and it's only now after 6 or 7 years of this running that some of the health boards are coming to me and saying, hey, wait a minute, we're beginning to see some differences here. And the critical thing about the areas that are beginning to report these differences is they've gone beyond the bounds of the original project. They've said, well, instead of just treating people with signs of heart disease risk, why don't we help them with advice around social problems they've got? Why don't we help change the local environment? Why don't we do a whole range of other things to connect them more successfully into society, organise well-organised things like social events and so on for elderly people feeling isolated. And suddenly, by doing a whole range of things, they're beginning to see differences. And I think the reason, as Derek has said, is we haven't stuck at it for long enough. I think, and we haven't done it at a big enough scale. The changes that come in from the Early Years Task Force have to be done at scale, and we have to stick at it till we see things happening. And we should see things happening quite quickly.
It has been the government's top priority for the last 6 years. There has been monitoring. The failure of local government and the health they work effectively has been present. The recognition of the early interventions in children has been recognised for some considerable time. What has the health department? What was the health department's response to Christie when they reported? What actions did you take in respect to that in the health department? And if we just take the last couple of years.
Yeah. So. Let me go back. I'll come back to your point about Christie if it's okay, but let me just go back a step before that. Because health was already doing a lot of work around prevention, targeted prevention and general prevention, even before Christie. And what we've tried to do with the Christie report through things like the change funds is raise our game on prevention. And as I said in response to your earlier question, this is not an area which is completely without success. We have been making some progress in some areas. So Harry raised the Keep Well programme there. just in the most recent statistics, actually the improvement in the most deprived areas in terms of improved cardiovascular outcomes are actually better than in the richest areas. Now, that's the first time, that, certainly to my knowledge, that that's happened. So there's not a kind of complete absence of success in this area. But as Harry described, 50 years of getting to the position that we're in. And I'm sorry, I'm not sure it's realistic to expect to see that 50 years of decline turned round rapidly in a relatively small period. It'll take a long time for us to recover, and it'll take a sustained cross-government, cross-civic society response to get us to a better position.
That's for some time. Who put the light on here? You know, what I presume at some point when you make something your top priority, you discuss all about the possibilities, the risks involved, what can be achieved, what's your objective, what's your measurements. On your measurement, your own measurement, I think you have conceded this morning that that has failed over that period of time. We have another task force coming up. What's going to radically change and push on and genuinely make this a top priority for government?
I would dispute the fact that we've known this for some time. I mean, when I first started looking at this, the answer was get people to stop smoking. When we actually looked at it, Scots smokers actually figure quite low in the European league table. It was all about diet. Well, maybe it is, maybe it isn't. When the fall in cardiovascular death rates that we've seen in Finland, for example, where they radically changed the diet, it's identical to the fall in cardiovascular death rates we've seen in Scotland, where we haven't changed the diet. It's much more complicated than you think, and this whole story has been bedevilled by people who knew the answer. It's much more complicated than anyone ever assumed. And even now, I mean, I probably know more about, you know, if you look across Europe, the number of European conferences I get invited to, somebody obviously thinks I know something about this. I don't know if we're at the end point of knowing the answer. Just in the past few months, a whole new range of scientific publications have suggested that there's an even more complicated layer of causation underpinning this. So we're not there yet. What we do know is that if we do these interventions in early years at scale and consistently, we will begin to make a significant difference in the health and well-being of the generation coming up. The question I would ask is, does civic society have the appetite to adopt the kind of evidence-based interventions to prevent young people going off the rails and ending up in jail, to deal with them when they come out of jail? I mean, I was speaking to an MSP recently who had visited Berlin recently and was told that people leaving Berlin are given 3 nights accommodation in a hostel for the homeless, and then they're on their own. Are we seriously thinking that that's going to help them get back into society and so on? We're just not joined up. And that's not an issue for the health department, that's an issue for everybody. So it's much more complicated than people think, and it will continue to get more complicated the more we get into it.
And I think we understand that, certainly in this committee and in other committees. One final question, I hope some of these themes will be taken up by the committee. But I don't know where that makes a point. We spent a lot of time on smoking and the focus on smoking. We spent a lot of time on the focus on alcohol, whatever, and they are not going to be the significant interventions. The same exposure for health inequalities has not been there. We haven't moved. We had local government outcomes, the whole outcome strategy, which hasn't moved the issue on. To move on and to get the committee and others behind you, we've got to recognise that the policy and the delivery has failed up to now. Why is there a reluctance to say that?
So when we published Equally Well back in 2008, I didn't hear anybody saying that's the wrong policy.
That's the problem.
But in the Parliament either, I didn't hear anybody say this is the wrong policy. Now, there's something like 78 recommendations on equally well. Actually, you can tell a reasonable story in terms of how we're delivering on most of those kind of things.
Messages have come through in terms of the figures that we're not achieving our objective. Our top objective was to reduce health inequalities. What was the response to Christie when his report came out? How did the Health Department respond to that? What actions did they take in response to the Christie report?
Well, the Christie report talks about prevention in its broadest terms. And so we've been up in our game around prevention in working in collaboration with our local authority partners. That's why you've got things like the change funds that we've got around older people, etc. There's a whole raft of things that we've been doing. The stuff you see most recently in the GP contract about anticipatory care, directly respond.
Early years are at the heart of this. Why are we only now getting to early years?
You're desperate to say
a couple of points. The first thing is that the recommendations of the Christie Commission, we had an input into that. So the need for focusing on preventative spend in part came from the recognition that a lot of the health services spend has been on prevention, things like screening and health promotion and all that kind of stuff. The second thing is, I would dispute the fact that previous things had failed. If you don't see a change, either a change hasn't occurred or you haven't collected enough data to show that there's a change. And I can take you round places that have participated in Equally Well where lives have been transformed by that process. The problem is we don't do things at scale. We do things that have good evidence base, we do them at small scale, and then we say, oh, this hasn't worked, so we'll throw it out and start again. What we need to do is build on the things that have worked across the whole of the system. And to say that now the answer is early years, the answer is not just early years. Early years is the way to break the cycle, but there's a whole range of other things we need to do as well. I'm looking for consistency and cross-societal action.
If it was a top priority, you know that screening and public health messages don't narrow that health gap. They widened it.
No, they haven't widened it. The gap has widened despite a number of things that have happened. It may have widened more if those things hadn't happened.
Bob Doris.
Thanks, Convener. I was struck during your initial presentation to the committee with the comments about over the last 160 years, the idea of health inequalities and life expectancy has pretty much been the same as the rest of Europe. It was the last 40 years or so where economic inequalities have widened, that the health inequalities have suffered greatly in Scotland. Now, two things that I think it's important to put on the record, and then I will come to early years because that's what I want to ask about. Firstly, economic inequalities are solved by using the economic levers of power to tackle economic inequalities. We don't have those levers of power within this Parliament, and welfare reforms have been widely accepted will increase economic inequalities within society, and yet again this Parliament doesn't have the power to prevent these damaging welfare reforms. Now, we've also heard today that this has been a priority in the last 6 years. In the hope for some cross-party consensus here, I darned well hope this has been a priority much longer than the last 6 years, and the previous Scottish Executive also had tackling health inequalities as a priority as well. And the concern that I have is that politicians who seek to criticise each other's schemes whilst in government as not succeeding feeds into that short-termism. So you ditch one scheme when the next government gets in and you replace it with another scheme. And we've heard here today that the chopping and changing is one of the significant issues when we should be mainstreaming the pilots that work at a local level. So with that now on the record, Convener, which I think is quite important to balance up the debate we've had here this morning, in terms of early years, I was quite surprised to see that out of a total of £607 million been spent on health inequalities in the previous 3 years, that the portion spent on early years was only £26.8 million. That does seem surprising. Is that an accurate figure?
Is that figure from the Audit Scotland report
Yes.
you're quoting? Yeah, I mean, Audit Scotland have derived those numbers from what we did back in 2008 as we published Equally Well. It was a kind of bit of a snapshot of where we were at that time, and we asked people to make some assumptions about what parts of their budget they were spending on health inequalities. So from that point of view, it's illustrative rather than definitive, I would say. And of course, there's a huge expenditure on things like education, which may not be fully reflected in those kind of numbers. So, you know, they give you a sense of where we were at 2008. Some of them include things for the 2008 figures that weren't known about for 2009, 10 and 10, 11, so they're excluded from the numbers. So, you know, I just treat the overall number with caution. It's intended to give you some kind of sense of the spend rather than necessarily to be a definitive statement of it.
It's very difficult to apportion time, say, in primary care. How much of the primary care spend is targeted at supporting children and so on. It's almost impossible to make any kind of judgment around that. So there will be a lot of activity around early years. And in other sectors, as Derek has said, things like nurseries provided by local authorities and playgroups and so on. All of these contribute to the early years effort. What we're concerned about is consistency, consistent application, doing the things that work at scale to level up the opportunities for families, to make sure families are supported, the kind of stresses that families will be feeling as a result of welfare changes just now, finding ways of supporting families through that period, because stressed families, the children tend to suffer if parents are stressed, and to make sure that the stresses that they do feel are not visited on the children is going to be a very important issue. So it's hard to quantify spend in these areas.
I appreciate it. I don't want to create an audit trail just for the sake of it and wrap the system up in bureaucracy, but Audit Scotland could only audit the figures that are collected. And I have to say that 26.8 million as a proportion of 607 million, given the early intervention agenda that we have as a parliament and as a government, does seem low. What are we not capturing in those figures that we should be capturing in those figures? In other words, if it is an underrepresentation, what kind of things should be, in cash terms, added to that figure so we can see what the global spend is? Because otherwise, I'm looking at that and I'm going, well, it's 26.8 million out of 607 million. That seems like a very, very small amount compared to everything else we're doing in health inequalities.
So those will be particular ring-fenced allocations of money. So they wouldn't include anything that was taken from more general allocations. So a lot of the money that goes towards funding health inequalities work in the local authority sector, for example, would be difficult to split out of that. The Audit Committee have asked us to do some further analysis of this work, which I think we will certainly have to do. But I don't think we'll ever get to that kind of definitive position of this is exactly how much we spend from every budget, because some of it's just almost impossible to split up. How do you allocate a health visitor's time between people who are in people we see in deprived communities and people we see in other communities? Likewise for social workers and teachers, etc. So it's, you know, we can do the best we can to get the most up-to-date picture we can get, but it will never be perfect. I'm sorry.
Okay, now the reason for you mentioned social workers there. The reason for asking the question was I was hoping it's up to you what answers you give, but looking at it from your initial comments, you were kind of moving towards health is wider than addressing the manifestation of health inequalities, but stopping them happening in the first place. And you mentioned social workers there. There are a variety of projects in our communities that are funded by the local authorities, by a variety of partnerships, which addresses early years issues. Are they captured within the £26.8 million?
No, I wouldn't think they are.
Right. Should they be?
Well, I think if we were sitting down today and doing the analysis that was done in 2008, we would, I think, try and do it in a different kind of way. I think that's the big... So as we think about how we respond to this committee's request for greater clarity about the numbers and the similar request we've had from the Public Audit Committee, I think there's a choice for us. Either we can try and update these numbers, or we can try and do a more... have a more fundamental assessment of exactly where we are today. And I have to say my preference is for the latter rather than the former, because I'm not sure this tells us the full story.
So health and social care integration, should we see a combined budget to address health inequalities in early years? Should that allow us to get towards what the overall spend is in relation to that?
And you can expect to see one of the products of health and social care integration to be a more targeted effort around health inequalities. Bringing the two organisations ought to help us make some progress on early years and beyond. But it wouldn't necessarily help you get beneath the surface of every penny that's spent, because a lot of it is still spent on general allocations and a lot of it is still spent on staff. And you need to do an awful lot of work in terms of understanding how staff are being deployed to get you, a accurate to the pound assessment of exactly what's spent.
Sir Harry, final question for yourself. You mentioned there's a number of pilots and good schemes at a local level that start to show evidence, and we axed them, we changed them, and that's happened over successive governments. Could you perhaps pick a scheme in terms of early years just now that's happening on the ground, which you believe should be embedded for the long term, and you wouldn't like to see it, whether on the vine, but to be invested and mainstreamed across the board?
East Lothian. East Lothian have, very early on in the introduction of Equally Well, they began a project looking at poorer areas in their local authority area, and they began to design a whole series of interventions, joined upness, social workers, voluntary agencies and so on, beginning to offer integrated support to families and young children. And that, the learning from that has spread to other areas. I could point also to Fife, where in Kirkcaldy, a project looking at young people's alcohol consumption has shown amazing collaboration between police, education, social work, health, to see young people's alcohol not as a criminal justice issue, but as a need for some sort of support. Other projects across Lothian Health Board area, the Family Nurse Partnership intervention. I mean, I probably shouldn't go into detail of individual cases, but there is no doubt in my mind that supporting teenage girls who are pregnant through pregnancy and through the first year or two of the baby's life transforms the lives not just of the baby, but of the mother. Mothers who in the past would have drifted into alcohol and all sorts of things, carry on at school, get hires, move on into careers as a result of the support they get from the family nurse. There's a lot of things happening out there that we need to join up, learn from, share the learning and spread. It's happening, but it's just happening in pockets.
I think that's really helpful. Convener, no further questions other than just to leave sitting there. Much of what you mentioned there, Sir Harry, would not be included in this £26.8 million. So I think we have to get a bit more clever at actually quantifying the money that's invested across a range of public bodies to tackle health inequalities in early years. And thank you for your answers.
Richard Simpson, followed by Martin McDonald.
I think, first of all, I'd say I entirely agree with the Chief Medical Officer that we're dealing with an extremely complex problem, and it's not for lack of effort by successive governments that we are still in a situation of having widening gap. When Labour came in, we visited the Black Report, and we looked at early years. And early years was a priority at that time for the UK government and the Scottish government. We reduced child poverty by a third, absolute child poverty by a third. We introduced Home Start, Sure Start, family centres, community schools. All these measures which were designed at least to deal with the 3+ group. But I think the new thing that Chief Medical Officer is pointing to is the 0 to 3 group and the very early stages of attachment and the fact that damage is done the first 3 years. I think that concentration, which was only reflected in Sure Start, Home Start and family centres, is perhaps the new thing. So my question is this. I think the last time the Chief Medical Officer came in front of us, he said that we could see, if we're going to be successful in tackling the early years, we should be able to see a pretty rapid reduction in infant mortality. That would be one of the things that we could see if we actually were on the right track and getting there. But in the last couple of years, we have seen a reduction in the number of midwives and a 40% reduction in recruitment of midwives. We've seen a focus on family nurse partnership, which will take 350 health visitors off into looking at a very small number of families, not into the second group that Gil Patterson was referring to, the slightly broader group. We've seen the caseload of health visitors rise and the caseload of social workers become almost overwhelming. So, when we say we're trying to address this problem and we're going to make a difference to this specific group of 0 to 3, all I see is everything over the last 3 to 4 years, not just in the squeeze that we're now facing, but actually the squeeze over the last 3 to 4 years has actually undermined the very thing that we're now talking about. So what I want to know is, apart from the family nurse partnership being rolled out, and I accept that and I value that, although it's actually a Scottish health visitor programme updated by an American who came to see our health visiting programme, but nevertheless it's interesting and useful, but it is expensive. How are we actually going to tackle it, and what outcomes will we see in a reasonable short time, as opposed to the very long time that I accept to see the generational change that we're going to need?
It's actually not 0 to 3 that we're focusing on, it's -9 months to 3. And it might even be before conception that we have to start thinking, as we think about young girls who will move on quite quickly into the potential for becoming pregnant, and begin to get them to understand a bit more about what pregnancy involves. Yes, we will see some significant changes early on. During pregnancy, attention to diet, attention to smoking, attention to alcohol, well, actually no attention to alcohol whatsoever, because I'm a proponent of not drinking at all during pregnancy, will reduce the number of stillbirths, they will reduce the number of low birth weight babies, and in turn that will have an impact on infant mortality, which is of course measured after the first year of life. We've already seen falling numbers of low birth weight babies in the most deprived areas, which shows that the messages out there in the cohort of midwives and support systems for women in deprived areas is actually working. We cannot do this without the support of midwives and health visitors. And as we move through this, part of the exercise developed by the Early Years Collaborative will be to look at the workforce and to look at the workforce implications and make sure that the appropriately trained workforce is in place to deliver this. A significant reduction in infant mortality is not entirely straightforward, because most deaths in the first year of life are associated with congenital malformations, which are unlikely to be significantly influenced in all of this. But the fact is, Scotland has already got the lowest infant mortality of the 4 UK administrations, and we think that the Early Years Collaborative at the end of this week will set itself a significant reduction as a target in infant mortality, bringing us much more closely in line with Scandinavia. So we are already seeing changes. the effort that has gone into early years in terms of low birth weight and so on has paid off a bit with the existing workforce as it is. But I think you're absolutely correct. We need to make sure that an appropriately trained workforce is in place. And as we begin to see the load, then I'm hopeful that investment from the Preventative Spend Fund will be made. I think I would want to say also, when it comes to social workers and so on, one of the things that I think is very important is to change the engagement with individuals and communities. At the moment, public sector engagement is all about caseload, it's all about risk management, it's all about protocols and guidelines. Actually, families in trouble and have spent a lot of time with substance misusing parents who are trying to do the right thing and move on. The best results come from the third sector, often, who sit down and engage with people on a different basis from social workers. The third sector can't take your children away. They're there to help you and support you, and therefore the trust that builds up is much greater. Now, having said that, in my own hometown, there is a very effective public sector project looking at substance misusing parents, but the critical thing is that the health visitors and social workers who work there are friends of the families. So a key part of this is a different dynamic. It's public sector workers, third sector workers, individuals, parents, communities engaging differently to co-produce different outcomes. Not us telling them what to do, but working with people to change their lives. And I think too often there's been a top-down, you will do X, Y, and Z, when in fact engagement with people to help them create positive futures for themselves requires a very different way of working with them. So it's not just about the workforce, it's about how the workforce engages.
So I must say my own experience actually matches that. When I worked in West Lothian for 3 years as an addiction specialist, it was the voluntary sector organisation that were able to actually intervene in a very positive way within families. But they are subject to the short-term funding that you referred to earlier. We have really, I don't know if you'd agree, but I think we've got to find a way that the programmes that work in the third sector have got to have long-term and core funding, so they're not spending all their time trying to, repeatedly tender. I mean, the tendering process is one of the most damaging things I found with my third sector colleagues. That we in the public sector, health, had no retendering at that stage at all. We're beginning to have it, and I'm not sure it's positive. So I don't know if you'd agree with that. So if we take the minus 9 months to 3, and very helpful answers on that, we're now, this next second group are the 3 to 16. And would you say that we are sufficiently identifying those with conduct disorders, those with who are being excluded from school, and picking them up in a way that provides the sort of wraparound support that you've just referred to for the 0 to 3s? Because it seems to me exclusions are rising again slightly, and that's not a criticism of the current government. Circumstances are difficult. And the other thing is that in terms of where we're at, the most striking thing that I keep referring to in this committee and in the chamber is the paper by Professor O'Connor showing that 14% of 15 and 16-year-olds in a study conducted in Stirling and Glasgow self-harmed. 14%. And another 14% had seriously thought of it. When we've got a society that at that age is producing 1 in 3 of youngsters saying that they're thinking about self-harming, there's something fundamentally wrong going on in that period from 3 to 16.
More work for the health visitors. We're reintroducing the 27 to 30 month health visitor assessment of developmental delay. As you rightly say, developmental delay is a sign that the previous years have not gone as well as possible. And therefore, at that stage, well before school, we would hope to be able to institute evidence-based programmes to put things right, with the aim of children arriving at school ready to learn, socialised, able to integrate positively in school. School exclusions are a particular, I don't know if irritation is the right word, but if a child needs to be excluded from school because of its behaviour, it's a sign that there's a problem at home. And what do? We take them out of school and we send them back to the environment that created the problem in the first place. Daftness. And this is one of the ways in which we need to rethink our systems. I have a particular interest in one way of dealing with that, which is the nurture group process, whereby children with these conduct disorders are taken into a special environment in school and helped to socialise. But the best thing to do is to stop that occurring by intervening early. So I think, again, we need to sit down across the whole sector. We need to sit down with the education sector, and we need to be encouraging the whole of society to think differently and join up. See a life as a course, not just a whole series of snapshots where this bit's failing, therefore we turf them out. No, we need to stop at them failing, and if they actually fall through the net, we need to institute appropriate measures. Things like enhancing play, enhancing reading of parents with children and so on, building up that attachment in the 3 to 5 age range is something I would expect the Early Years Collaborative to have something to say. And then looking at children in their teens who suffer significant mental problems. Again, the origin is very often in the first few months, years of life. And hopefully we will begin to see those sort of issues like self-harming as the cohort comes through from the early years interventions. We should begin to see that being reduced. But it is a sign of stress and lack of self-esteem and so on that we need, I think, to be thinking more clearly about intervening at that school age.
I'm not going to tackle the third group. I'll leave that to other members. But just to make a final comment, in the previous Parliament, we heard evidence from the professor of in relation to speech and language. I think it was Queen Margaret University, saying that the gap between the problem starting and the referrals had got longer, not shorter, because of the health visitor situation. So I welcome the introduction of the 27-month look at to see what language delay is beginning to occur at that point, because early speech and language prevents you going to school with that difficulty, which then creates further problems. And the other final comment I'd make is I've been working with a charity called Place to Be, which has been working with 10 schools in Niddrie and has a lower rate of exclusions and deals with exactly the sort of in-school nurturing you're talking about. That programme has been expanded to Lothian, East Lothian, though it's under threat there because of finance, because the NHS is not playing its part in funding that section, and I put that on the record. I hope that is not going to be the case. I hope the NHS will, as it does in the Niddrie situation, fund the East Lothian one as well. And there's a pilot in Glasgow too, which is now being looked at. It's not the only programme I accept, but this sort of programme that works needs to be expanded, and it is not an expensive programme, and it has a huge effect. With 70% of the children in those primary schools actually going to the counsellors to talk. So actually augmenting their own family ability to talk about problems with this in-house, but separate from the education system, charitable support. And I just put that on the record because I will return to that in the debate on mental health later this week.
Mark MacDonald.
Thank you, Convener. I think picking up what Bob Doris was saying, I think that the point was well made that if we're talking about 50 years of widening inequality, this, the year zero, as it were, for this issue goes back some distance and predates this Parliament. And I think the point is also well made that the indication that you appeared to be giving, I appreciate you're not here in a position to be able to talk about some of the wider policy approaches, but the indication of your remarks is that the response is hampered with a lack of control in some areas that this Parliament does not have controls over. I think it's also clear that, and clear from the discussion so far, that politics doesn't do the long term very well and never has. because the electoral cycle tends to get in the way, and there's a difficulty of messaging, if you will, that if you say to somebody that an intervention that you are proposing at this stage is going to take a number of years to manifest significant improvements, unless you have complete buy-in to that and an agreement that we accept that it will take a long time for the results to show, and therefore you won't have governments or politicians of whatever colour being hectored for a lack of progress, then we're always going to be in a position where for want of a better analogy, the baby is being thrown out with the bathwater on these issues. So, I guess, what can we do to try and ensure that there is a sort of an acceptance that some of these measures that you are talking about are going to, by their nature, take a long time to show the kind of dramatic improvements that people clearly are wanting to see?
I think it's one of the things that the Early Years Collaborative has the potential to offer us, because the strength of the approach that we're going to use. So what we're trying to do in the Early Years Collaborative is bring the kind of methodology that we've applied, for example, in the patient safety programme. That kind of clear understanding of what it takes to improve to the early years agenda. Now, it's a much more complex agenda. This is, no one's tried anywhere in the world, as far as we can establish, to do the kind of thing we're going to try and do in early years at the scale we're going to try and do it. But the power of the methodology is that you collect the data as you go along. So that, we're going to have every community planning partnership in Scotland together on Thursday and Friday this week. And we're going to send them off to do some stuff from next week and start counting. Start counting the impact of the changes that they're making. And the power of the data in the approach we're using is not the big kind of multi-year evaluation, but the fact that you count every day. And so at least there's the prospect of getting some sense of progress as you're working on the programme. Now, it's not the kind of progress that would stand up to randomised control trial or necessarily would be accepted in peer-reviewed journals, but it ought to give us some sense of whether we're heading in the right kind of direction. So it's early days. We're just about to start this work, but we're hopeful that by collecting the data as we go along and going through those plan, do, study, act cycles that are part of the programme, you start to collect the data as you go along.
In terms of the long-term nature of this, I've come to this through science, not through opinion or my own sort of political views or anything. I mean, I was an adult surgeon by background and got interested in health inequalities, and over the years the scientific evidence is utterly compelling around the importance of positive and nurturing early years. I can show biochemical changes, I can show neurological changes, I can show all sorts of very precise linkages between things that happen in early years and subsequent risk of things like heart disease and stroke and cancer and a whole range of other mental health outcomes and so on. So politicians, on the whole, are rational people. And you present them with that scientific evidence, you present them with the evidence that says these policies are causing neurological abnormalities or biochemical abnormalities, but these interventions are changing those biochemical abnormalities, then people tend to accept that. And I have to say that since I've been involved in policy, I've worked closely with every health minister since Sam Galbraith, and they all want to do the right thing. You know, it may differ slightly in terms of how they want to achieve that, but, you know, they all want to do the right thing, and I would earnestly hope that that would continue, no matter what happens in future. The evidence is very strong that we'll break the cycle here, but there are other evidence-based things that we can do later on in life that will change the biochemical predictors of poor outcome, that will change the neurology, that will change the DNA changes that take place, and we've observed in affluent and deprived citizens in West Central Scotland. So very clever scientists are on the case here, and all the evidence suggests that if we do what we're going to do on Thursday and Friday, we'll begin to see significant improvements in a new cohort of Scots that will lead to a great reduction in the difference between affluent and deprived Scots.
Sure, and I mean, obviously there was some discussion earlier around whether the public health messages and public health campaigns have succeeded or failed. I guess the only way we could have definitively said one or the others, we could have established maybe a control group on St Kilda, but that would have possibly been a little inhumane. But I agree with your point that the early years is absolutely crucial. But obviously beyond the early years, there are a great number of Scots who have left that cohort and are part of the figures that we see in terms of health inequalities. And I guess the worry would be is that how do we ensure we don't take our eye off the ball there? Because obviously we don't want to essentially be writing off a whole generation or generations of Scots and say that they are beyond rescuing from the situation in which they find themselves. So what you know, in a nutshell, what's the answer in that regard? Where do we go from there?
It gets harder the older you become to make these sort of changes in your life. We certainly think there's a lot that we can do in terms of reducing offending and reducing reoffending. There are some very specific interventions that we're discussing with colleagues on that. But one of the key things, one of the reasons that behaviour change interventions are less likely to work is this notion of locus of control. As a surgeon, I used to tell people to stop smoking or, you know, to eat a healthy diet, and you very often got the response, if you're going to die of cancer, you're going to die of cancer. It wasn't within their control to make changes that would reduce the risk of dying of cancer. It was some kind of external focus that was determining their future. External locus of control, the psychologists talk about. This sense of control, we know from the psychologists that it's built in early years, but it can still be developed later on in life. And part of it comes down to this business of engagement. The notion of individuals participating in decisions about their environment, their community, and so on, the classic phrase is empowerment. You know, have we really tried to apply that in deprived areas? I've been working in one or two deprived areas, trying to get people engaged, people who have become very much dislocated from society in general and live very solitary and very damaged lives. And when you do get them involved, they change. Their decisions about their health and well-being, their decisions about participating in society more generally, they become involved. And I've seen people, I mean, it's invidious to talk about individuals, but I know of one individual who was housebound for 7 years after the death of a spouse and was changed by an empowerment type of intervention. And that individual is now the focus of a huge amount of community work in that area. So it comes back to my point about the changing nature of how we engage with society. Do things with people, not to them, and get people engaged. And that will begin to suck in middle-aged and older people. And I probably can't talk about middle-aged and older people without a plea for physical activity. 2.5 hours of physical activity a week. If everyone did it, life expectancy in Scotland would increase by a year. Very significant intervention. But again, folk who are isolated, why would they go out, take an exercise? They need to feel they're part of a group and become engaged.
One final question, if I may. I accept entirely the point about the inequality playing a huge factor, and we can look to, for example, the index of multiple deprivation as a guide for where intervention is most likely to be required. But beyond that, I mean, Gil Patterson talked about communities he could take you to. I could take you to, you know, what we call middle class suburbia, and even within that, I mean, I could take in my school yearbook and point to people in that yearbook who perhaps became teenage mothers, or who perhaps became addicted to drugs. People who came from communities that wouldn't even come close to touching Scottish index of multiple deprivation figures, but there were still people within these communities who would be at risk, or could have been identified as being at risk. And I guess, do we need to get smarter even than just the index of multiple deprivation in terms of how we identify at-risk individuals, never mind at-risk communities?
Absolutely agree with that. I think we should not be drawing circles in a map and putting all our effort inside those circles. We should find more sensitive ways of finding people who need help, and help support engagement should be available to them on the basis of need, not on the basis of postcode.
There's some data from the Scottish Household Survey, which is it's a little bit out of date now, but you can draw some conclusions from it, I think, that showed that about 34% of low-income households lived in the 20% most deprived areas. And I don't know about the committee, but that surprised me. I would have expected that number to be significantly higher, 34%. So that means that 66% of low-income households are not in the 20% most deprived areas.
The universalism plus.
Do everything.
How is that reflected then in the Health Department's policy in terms of looking at some of those areas and ensuring that there are adequate resources within that particular area?
One example is the Family Nurse Partnership. Any pregnant, in the areas that it's currently operating and when it's rolled out across Scotland, any teenage girl who becomes pregnant will be offered a family nurse, irrespective of where she lives. You know, that kind of thing. It's relatively easy to identify that situation. It's harder to identify other things, but we are constantly looking at ways of identifying those, and we will be using community planning as a major effort in that. We
have though, since I think I was last on the Health Committee discussing this, access to GPs and time with GPs for, I don't know, many years now, to deep end have been going. You know, it's another area that, you know, do you feel that needs to be addressed? Or?
Yeah, and we are in very active discussions with the deep end practices. There's a piece of work that Stuart Mercer's doing just now that's looking at the impact of more time with patients. But if you, again, the Audit Scotland report has, I think, quite an interesting analysis of where GP practices are, and there's not a direct correlation, but there still are significantly more GPs in the most deprived area compared with the least deprived area. And I think part of the other response to your question, Convener, is in some of the things we've tried to do recently around the heat targets in health. So we set a target for smoking cessation services. It's a universal target. But we made it particularly challenging for the boards to achieve in the deprived areas. So we expect them to do more in deprived areas than they do in the country as a whole. We've done the same on things like fluoride vanishing, where again we've tried to give a particular emphasis to boards upping their performance in the deprived communities. And I think it is about doing both.
We've also spoke briefly about the role of COSLA and local government and the wider delivery. What are we doing to improve the performance of community health partnerships in that area and those relationships with the local authority?
So the committee will be aware of the statement of ambition that was published recently, the revised guidance to community planning partnerships. It's got inequalities as a key priority, one of 6 big priorities for community planning. We've very deliberately taken the community planning partnership as the kind of the collaborative home, if you like, for the early years collaborative, so that we're going to have on Thursday and Friday people from local authorities and people from the health board sitting around the same table, producing a joint plan for the kind of changes that they're going to make in their community planning partnerships. So I think we've got a strong signal in the community planning guidance that this is a priority, and we've got people coming around the table to work together at the local level, which is where you'll see the improvement happen.
Drew Smith, followed by Nanette Millen.
I did want to go back to the Audit Scotland report. I mean, just picking up that point about primary care, first of all, you know, there's a key message in there. You said that there is a greater correlation of there are more GPs in deprived areas than less deprived areas. But the key message from Audit Scotland report says the distribution of primary care services to Scotland does not fully reflect the higher levels of ill health and wider needs found in deprived areas. And their second key recommendation is that you review the distribution of primary care services to ensure that needs associated with higher levels of deprivation are adequately resourced. I mean, are you going to do that?
So Harry will want to say something about this in due course. I think we should constantly keep that under review. But a few things I would say. Firstly, there are more GPs per head of population in Scotland than in any other 4 countries. We have more GPs, full stop. Second, you wouldn't see, I know there's no direct correlation, and so Audit Scotland are right in that regard, but you wouldn't see that gap between most deprived and least deprived that you see in Scotland in other bits of the UK. So it's not as if we haven't got any kind of correlation at all. There's a significant difference between most deprived and least deprived in terms of the numbers of GPs. We have a limited number of levers in terms of what we can do to require GPs to set up in any particular location. There are some things we can do. We can make sure that there are better premises, for example, in those deprived communities, and we're doing some of that. There's going to be a new health centre funded in Postle Park, for example, one of the most deprived areas in Glasgow. It will be state of the art. It will be a outstanding primary care facility. You can do that kind of thing and invest in those kind of initiatives. But there's very little I can do to force a general practitioner to set up in any particular location. Then it's also, I think, about what it is the GPs are doing in those kind of areas. And I think that's where the work of the deep end GPs is really interesting, in terms of how can we adapt the practice of those general practitioners to better reflect the needs of their customers and clients. There are some things that we've started to do now in the GP contract. So the failure to agree a GP contract at the UK level has given us an opportunity to agree a more Scottish contract. We've prioritised within that more Scottish contract something around anticipatory care, which picks up the convener's earlier point about what you're doing about prevention and anticipation. So we're trying to pick that up in the GP contract, and also something about multimorbidity, which is a particular challenge in deprived communities. Of course, we should keep the distribution of GPs under review, but that in itself is probably not enough. We need to think more holistically about how we're using the GPs, what's the nature of the practice, how can we incentivise the right kind of care for people in deprived communities. And Harry makes more eloquently than I do a point about where people are distributed, so I'll let him do that.
Just because you live in an area doesn't mean you're registered with a GP in that area. We looked, I remember a few years ago, looking at, I think it was Drumchapel, looking at the residents of Drumchapel, and we found that they were signed up with something like 100 different practices across Glasgow, spread all over the place. So you just can't plonk a GP in an area and say, okay, suddenly, yes, there will be more GP time available to people because a lot of them will sign up with that GP, but, you know, it's very difficult to estimate the amount of GP time available to residents of a specific area because they sign up out with that area. The other point I would make is that primary care is a lot more than GP time. We've been talking about health visitors, whom I consider to be an absolutely essential part of what we're trying to do. But I would increasingly see primary care expanding, as it has already done in some areas of Scotland, into a whole load of other disciplines that aim to support, given our interest today, families in different ways. We're seeing health centres that have welfare rights people involved and all that kind of thing, just generally expanding the ability to support people in difficulty. I personally would want to see us working more closely with local authorities on things like signposting, people who need help for specific things that might not necessarily come from the health service. And one of the things that, and I've already spoken about physical activity, we're going to have some way of making sure that GPs hand people on who need some help with physical fitness to another layer of intervention, and the best way to do that is to get physical activity coordinators and so on working in primary care. So primary care we will see expanding into a whole load of other areas beyond just general practice. And I think that's absolutely right and reflects this whole society nature of the problem that faces us.
I mean, to be fair, I did ask about primary care. I didn't ask specifically about
sure,
GPs.
Yes,
so,
absolutely.
So I do accept that. I mean, I suppose there's a challenge here for us because every question can be answered with it's very complicated. And of course it's very complicated, and I think all of us around the table accept that. What I'm trying to get a sense of is the extent to which Audit Scotland have put something in front of us that where do you think it is fair, and where can you demonstrate that there's a change that you're going to take because that has been a useful exercise to have Audit Scotland's report. So the Chief Medical Officer said that he absolutely accepts that short-term and small-scale interventions are disruptive, are not the way to do it, and you went further than that and actually advocated that rather than just accepted it. But they're also saying, NHS boards are failing to allocate resources to target needs within their areas. What is the response to that? What action are we then going to take when someone tells us that? They say that there's a lack of shared understanding of what health inequalities are at the local level. So not just the concern that you've got around, the causes of this are all complex and we're not going to get, we don't have a definition of, we know that's the cause. But at a local level, there isn't even a shared understanding of what the symptom is and what the cures might be.
I think we've already pointed to the fact that some of the arithmetic around the expenditure has left out a lot. Of necessity, a lot of expenditure on health inequalities is going to come from areas that are not health, and therefore I think we're moving in the right direction, strengthening community planning and community planning partnerships in order to bring funding together. What we forget is that in terms of health care, all that funding that goes in health care is skewed towards health inequalities, because the reality is that people living in deprived areas are more likely to get cancers, heart disease and stroke, and therefore they get treatment on that. And when I had a specific interest in cancer as a surgeon, I looked closely at the pattern of treatment, because outcome from some cancers, from most cancers actually, varies by socioeconomic status. The lower down the social scale you are, the less likely you are to survive. In fact, and therefore one of the obvious explanations for that is that there's less treatment available for people in deprived areas. Couldn't find any evidence of that at all. What I did find was more aggressive cancers, more aggressive physiological responses to those cancers. I found a biological explanation for it, one that incidentally has been shown elsewhere in the world. Other countries have now shown that. So most of the health services spend on health care is actually dealing with the health services response to socioeconomic deprivation, because it's tackling it in real terms.
mean, I think probably one of the purposes of this inquiry is that, you know, these are all questions that we need to ask, and we'll have to have other panels in front of us. But, you know, I don't think it's unreasonable when you're presented with the Chief Executive of the NHS in Scotland and the Chief Medical Officer that we concentrate on the NHS bits of this. So I suppose the question that I would have is, are there things that the NHS Scotland does currently that increase inequality?
The obvious one is anti-smoking campaigns. Historically, any time someone has had a targeted or has had a campaign around health behaviours, the people with the stronger sense of control over their lives respond, and those that don't respond. So traditional health improvement projects widen health inequalities, which is one of the reasons why I felt we had to move beyond that.
I mean, that would presumably also be the case when, in terms of thinking about physical activity and how we then shape campaigns now, that we don't repeat that mistake.
Absolutely. You know, discussing this recently with someone, and I got the response, poor people don't take physical activity. Well, if we keep telling them that they don't take physical activity, they ain't going to take physical activity. We've got to find other ways of dealing with this. And again, I live in a relatively deprived area, and the efforts being made by my local authority to have running groups and so on are really very striking. You see the evidence on the streets of the town. So we can do it, but it's a question of attitude and culture. Do we really want to make a difference here? Because if we do, let's find ways of delivering the intervention.
I think I would still have a question about other things that we do as a National Health Service and as a Health Directorate of the government that increase inequality, that are beyond just the public health campaigns. Because the big challenge in all of this is and I think Mr. Feeley, you mentioned it earlier on, was that thing about redistributing power and income and resources. And you know, what the Chief Medical Officer is saying around small-scale projects, you actually need big budgetary change then to deal with this, which leads you on to the question, we're going to need to divest from something then, aren't we? So what I would be looking for, presumably the question that you're asking yourselves, are if you're aware that you need to divest from somewhere, aware that you want to move more money into inequality, then presumably the place you would start would be, what are the things that we do that we know don't work to reduce inequality and may even make it worse?
So there shouldn't be, you shouldn't have a litany of such projects, because we do inequalities proof our policy making as it goes along. So as we're developing the policy, we're asking ourselves, are we clear about what impacts this is going to have on all inequalities, not just those that are income generated or socially generated, but all inequalities. So there shouldn't be a large number of policies that increase inequalities. I think there is a real question to be asking ourselves about, have we got that balance right between the policies that will improve health for all and the policies that will, what Harry called, level up. And I think that's an open question in terms of whether we've currently got that kind of balance right. I hope that I gave you some assurance when I talked about some of the things we've recently started to introduce around the heat targets, that we're trying to influence behaviours in that kind of way. Projects like Detect Cancer Early, it explicitly recognises that some of the issues around cancer outcomes are about the fact that in deprived communities people tend to present later with cancer, and so we're very deliberately going after that segment of the population. But we have a duty to all. We have a duty to improve everybody's health. But we have a particular duty, I think, to improve the health of people who are currently health deprived, and we need to get that balance right.
Could I just ask a final question, Convener, which again goes back to the Audit Scotland report, and it's the first recommendation that they have made, which was that the Scottish Government should introduce national indicators to specifically monitor progress and to report on that progress. Because I think the Chief Medical Officer made the point, of there's been a lot of people around these issues for a long time, but how do we, as a committee, reassure ourselves that we are not, when our report is published, that in 10 years' time, you know, another chief medical officer and another head of the NHS in Scotland, and probably a good few health ministers later say, well, it's complicated and it's difficult to measure progress, so we don't.
How do you know I won't still be here in 10 years?
I'm pretty sure I won't. So I was puzzled by that recommendation in the Audit Scotland report, and I said as much to the Public Audit Committee. At the bottom of page 10 in the Audit Scotland report, there's a footnote that refers to the long-term monitoring of health inequalities, Scottish Government, October 2012. It's footnote 22. It's the only reference there is to the fact that actually we're one of the few countries, I think, that report annually on progress in these areas. And so every year we report progress on healthy life expectancy at birth, premature mortality, mental well-being, low birth weight, hospital admissions for heart attack, heart disease, cancer incidents, cancer deaths, alcohol admissions, alcohol deaths, and all-cause mortality. And by socioeconomic status. So I think to suggest that there's no monitoring of these things, I think isn't supported by that kind of evidence. Now, if the committee wanted to offer us some advice about whether these are the right kind of things to be monitoring, that would be incredibly helpful. If there were other things that we should measure, either by substituting some of those or by adding to them, again, very open to that. But there is regular monitoring of health status in those kind of areas.
Thanks. A couple of supplementary. I mean, I've got one, and I think Gil's got one. In terms of the treatment, you know, for poor people get more than their fair share of treatment as a negative, I presume, and that they've left it too late, and you know they find themselves in hospital. Who gets the biggest share of the preventive, biggest benefit of the preventive measures? The richer, the poor, or the middle class and the poor?
Preventive measures are things like cervical screening, breast screening, and so on. Everyone is invited for screening, but uptake is lower in poorer areas. And
evidence for that?
There is evidence for it, but there's also evidence that people within primary care and so on make extra effort to encourage folk. But it comes back to my point about people feeling in control or not in control of their lives.
I was just trying to get some clarity over the treatment and preventive. The preventive is the important stuff and where we want to get to.
Increasingly, yes. Absolutely. Yeah.
The other thing, I suppose, that's came out is that, you know, and we all plead guilty to this, about what's important for politicians in terms of the outcomes, and this at the heart of what needs to change to get us to a preventative agenda and dealing with this health inequalities. And we measure success. Indeed, Cabinet Secretary was measuring success in an article on Sunday on the basis of keeping a hospital open or hospitals open or you know, smoking, you know, ban, you know, things like that. Do we need to make a journey here? Why are we not listening? You know, why has your interventions on the policymakers over a period of time not been more successful and, you know, and encouraging us to measure health outcomes in a different way, not on terms of a free prescription or a hospital or access? You know, we spend as a committee, or have spent a lot of time on end of life, on older regulation of older care and the delivery of older care, when the key, clearly, as you're saying today and have been saying for a number of years, is that we need a different direction and different priorities that go to the key that can unlock this, which is early years intervention. We're just not getting there, are we? I
think the challenge, Convener, for policymakers and for parliamentarians alike is that all of these things matter to people. And we all spend some of our time doing what's urgent and some of our time doing what's really important. And I think if we could get to the end of this committee inquiry, I mean, if I take you back to the first words I said, I very much welcome this inquiry. I think this has got the potential to put us on a course where there's a sense of kind of consensus, shared purpose, a recognition that a number of administrations over a number of years have done their very, very best to resolve some of these big and complex issues. But if we could just get some agreement about the kind of core of things that we're going to prioritise over the next 10 to 15 years, I think that would be a significant step forward. And then I think there's a legitimate challenge on us to get on and deliver some improvements.
Is it a case, I mean, I think you, Sir Harry, you alluded to some of this earlier. Is it a case that the poor are less likely to vote and the worried well vote in large numbers? Is it, do we need to overcome that as politicians to get to some of these?
Well, I mean, it's not an area of expertise in mine, voting habits, thankfully.
I said earlier, Sir Harry, that in the courts and early interventions with young people and trouble, we had to overcome society's feelings about that. Does that not come down to politics and voting and whether a hospital stays open or whether it doesn't? Or?
I think there is a real cultural change that we need. Instead of blaming people, see people as being in need of help and support, no matter what position they're in. One of the first things I did when I took on this job was go down to Carstairs. And I've probably met about a dozen mentally disordered murderers over the years. Every one of them has a history going back before the age of 3. Their lives have been blighted very early on. They've been excluded from school. They've taken refuge in drink and drugs in their teens. They've wandered about town with a knife in their pocket, and sometimes somebody gets stabbed. The mental ill health that comes from abuse and neglect in early years is hugely dominant in the lives of these individuals. And we've got to get away from an attitude that says, the answer is lock them up forever. And, thankfully we've got we've got places like Carstairs that actually tries to work with them on their mental disorders. But to a greater or lesser extent, you can see that in folk in Barlinnie and other prisons, that failure in life has its origins at that early stage. And it's a cycle. People who are neglected in early life will in turn, they haven't learned to attach and nurture their own children in turn, and therefore the cycle's perpetuated. And I think that to a large extent accounts for the gradual widening, the accumulation of that adversity in our society. If you ask me, what I am really looking forward to are the results of the 27 to 30 month health visitor assessments on developmental delay. When we see that changing, we're seeing real evidence of a shift in the way pregnancy is nurtured and the way the first couple of years of life are nurtured. And the fewer developmental delay kids we see, the fewer children put on the risk register and so on, we're then seeing real change in our society. We can look forward to closing a few prisons in future.
Do you think then that how we measure health inequality should be measured another way than we currently do now, or does it matter?
I think what we've got, that comes off more or less routine statistics. What the Early Youth Collaborative will do, it will, as Derek says, it will identify almost on a day-to-day basis the number of women attending antenatal clinics who smoke, the number who've been given smoking cessation advice, the number who've taken that smoking cessation advice, the number of women who continue to drink alcohol during pregnancy. That will be that will be on a chart on the wall, and we'll see it coming down or flat or whatever, and if it's flat, we need to redouble our efforts. We're going to get into an era where we're measuring a lot more around growth and development of children, and we'll determine from that which are the most sensitive measures. But the one thing, come back to, it's human nature to look for a magic bullet to solve complex problems, and the magic bullet doesn't exist here. It's a lot of hard work across the whole of the life course that we need to pull together. And if we get that realisation out there in a sense that the whole of the system needs to work together on this problem, then that will be a mighty leap forward.
I'll pass and followed by Nanette Millen.
Thanks. Very, very quickly, I think Sir Harry spoke about people presenting, and associated with that is people who make appointments to doctors. And as I understand it, in the most deprived areas, then the prospect of people not turning up is very, very high. Is there any work? Is there any schemes in place where we can, go and get people to present and keep appointments that will effectively change the situation for them?
There are successful interventions. I mean, most folk have a mobile phone, and there are systems by which people get text reminders of when their appointment is and all that kind of thing, and that has a significant effect. Again, it's doing these sort of these interventions that work, doing them at scale, and making sure that everyone participates in all of this. So yes, there are things that are happening, and they are having an impact.
Thanks very much for that.
Can I apologise first of all for being so late in getting here? It was thanks to a broken down train, the ScotRail. So I probably missed quite a lot of what was said at the beginning. But I mean, I've been around long enough to have seen a lot of changes come and go and then come again, within the health service. And whilst I've never actually been in general practice myself, my husband was a GP in a practice that covered most of Aberdeen for most of his working life. And the way things went, it's maybe back to the future, but there they had a practice nurse, they had a health visitor, they had social worker, all pretty well attached to the practice, who met very regularly, several times a week. And it struck me that really got to the root of problem families within the practice, and situations could be dealt with, before babies were born. They anticipated there might be an issue with a particular family and so on. And I think that's probably what you were getting at, Sir Harry. It was the sort of local collaboration, and it does strike me, it's maybe back to the future, but it does strike me that maybe is the way ahead. And that's more or less a comment rather than a question. The other thing, so do you think really that we should be going back to practice-based health visitors where possible?
I think we need to go a lot further than that, not just have practices, because we mentioned earlier on the fact that people sign up with practices all over the place, not just in their own area. And I think, from what I can see, we need a much more widely coordinated effort that brings social care, it brings educational interventions, it brings preschool interventions together in a coordinated way across the life course. And obviously we're focusing a bit on early years here, but even as children move into secondary school, these transitions between primary and secondary school can be very stressful, can knock kids off track and so on. Things like Place to Be, which Richard Simpson mentioned earlier on, very important ways of supporting children through these transitions. So I think we need to do far more than we ever did. I absolutely accept that in the old days it was possible through a from having lots of people seeing a situation, synthesize ways of dealing with it. But we need to get even smarter, because the problems in some areas are really very severe.
The other thing was, maybe to follow on what Gil Patterson was saying about access to primary care. I had a very interesting meeting recently with somebody from Optometry Scotland who had a practice in a deprived area, and he felt that they were a very good point of entry to the system, and that they people would be quite happy maybe to go and get their eyes tested, but then they could signpost them to the wider health services. The same, I presume, would apply with community pharmacy, and I could see quite a lot of collaboration at local level there, which would be quite beneficial.
That's absolutely right. Dentistry is another example where people can be signposted on, and we're working really hard to make sure that the contractual arrangements with our independent contractors in those kind of areas reflect and incentivise those kind of signposting, so that any engagement with primary care becomes one that's not just about the treatment, but about information and about guidance and about signposting to other services.
And that can be at all ages, really.
Absolutely.
Okay. Thank you, Convener.
Thank you. Elaine MacLeod. Aileen.
Thanks, Convener.
See you a moment ago.
You've said earlier about this is an issue for the whole of society, and it's not just an issue for the health service, and that what we are looking at is really an intergenerational failure. And I think in your annual report, Sir Harry, I know that you talked about the implications of people's genetic makeup and how this can be affected by their socio-economic environment, which can be passed from one generation to the other and then becomes embedded to the point where it becomes the norm. It's part and parcel of kind of people's culture. And obviously, as you said earlier, this perpetuates the cycle. It also accumulates in a variety of health inequalities, as well as the current inequalities in terms of income, welfare and power. So it's just really how do we kind of deal with the challenge, I guess, of the kind of genetic makeup.
I mentioned epigenetics because it's emerging as a real issue in some studies. We do not have a specific epigenetic study yet. We've measured in affluent deprived Glaswegians evidence around chemical changes to DNA that are often associated with epigenetic change, and we have identified those. But I mention that just to underline how complicated the problem is. Whenever you think you've reached sort of reasonable approximation to the answer, some new aspect of science comes in and you think, wow, how does this affect what we're doing? So in the course of the next year or two, we are planning to conduct some studies in Scotland to see to what extent epigenetics may be contributing to this problem. That particular issue arose from a study carried out in Sweden where they had data on nutrition and health going back to 1900 over several generations of people in quite an isolated part of Sweden. And they found that the risk that was accrued to young men and women in the early 1900s was expressed in at least two subsequent generations, irrespective of their experience. So the geneticists are saying that there is now good evidence that you can modify the activity of your genes in ways that can be passed on to subsequent generations. We know too that some of, it's very leading edge research, but some of those epigenetic changes can be reversed very easily. And, so it's a work in progress, but it just underlines the fact that there is no magic bullet here. There's a complex biological consequence of adversity that gets handed on round a cycle from one generation to the next. But the jury's still out on this as far as Scotland is concerned.
Okay, thanks very much.
Aileen. I've got an indication, another question from Bob Doris. Is there any others? No? Bob, final question.
Just very briefly, Convener, as I was hearing more information about the early years collaborative and going beyond, it's a societal issue as people investing and being in control of their futures. I've got a local housing association, North Glasgow Housing Association, has appointed a full-time sports and activities coordinator through wider role funding, and that's starting to make some significant local impacts. They see themselves as a kind of core investor within their community. Are those types of organisations going to be part of the early years collaborative approach? I'm just keen to get a sense of will it be the usual suspects, or will we widen out that approach to every stakeholder in communities?
Absolutely, you're absolutely right. I mean, I've seen Glasgow Housing Association generally and other local housing associations in Glasgow beginning to get really involved in this whole agenda and being very significant in it. The critical thing, I come back to my point, is it's not about top-down, it's working with people to develop some new set of opportunities or insights, or giving people some control over their environments. So we would very much want to see housing associations and anyone else who felt they had a role to play in this to be involved and actively encourage it.
And they are being actively encouraged, are they, as part of the early years collaborative? How's that taken forward?
One of the ways in which the collaborative works is it gives control over the changes that are made to the people in the localities. So we don't tell them what to do. We give them a range of options that they can follow, and there are certainly options around physical activity that are on that menu. I think the other bit of comfort I would give you is that, and Harry alluded to this earlier, we're currently considering how best to bring some of this approach to physical activity. And there'll be a bit of that that's explicitly connected to the early years collaborative, and there'll also be a bit probably that we want to do because everybody benefits from physical activity, not just children, that we want to do separately and in a connected kind of way. So, you know, even if they weren't formally part of this, of the early years collaborative, there's no reason why they shouldn't be part of a broader physical activity collaborative piece in due course.
Very much. Okay. Yeah.
Can I thank you both on behalf of the committee for your evidence given this morning, and we look forward to examining and working with you with the work you'll do in the future. Thank you very much for your attendance. Thank you. We suspend at this point and set up for the next session and the panel, please. We now move to agenda item number 2, which of course is our first evidence session and an inquiry into teenage pregnancy, and a welcome to the committee to you all. I think it may be useful that we just introduce ourselves as we go around before I ask for the first question. My name is Duncan McNeill. I'm the MSP for Greenock and Inverclyde and the convener of the Health Committee.
Okay, I'm Nicky, Coia, Principal Health Improvement Officer for Sexual Health with NHS Greater Glasgow and Clyde.
Bob Doris, MSP for Glasgow and also Deputy Convener of the Committee.
Morning, I'm Anne Eriksen. I'm Executive Lead for Sexual Health and Bloodborne Virus with NHS Tayside.
Gil Patterson, MSP for Clydebank and Mulgai.
I'm Gareth Brown. I lead up the Blood, Organ Donation and Sexual Health team in Scottish Government.
Richard Simpson, MSP Mid Scotland and Fife.
Felicity Singh, I'm the Sexual Health and HIV National Coordinator at Scottish Government.
Drew Smith, MSP for Glasgow.
Mark MacDonald, MSP for North East Scotland.
Maggie Watts, I'm a consultant in public health medicine with NHS Ayrshire and Arran, and I'm the sexual health lead for them.
Ailey MacLeod, MSP for South of Scotland.
Lorna Watson, I'm consultant in public health medicine with NHS Fife and leading sexual health strategy.
Nanette Milne, MSP for North East Scotland.
David Torrance, MSP Kirkcaldy constituency.
Thank you for that. Before we move to our first question, I will always give precedent to our guests and our witnesses here today, and I think the MSPs understand that. And obviously, we're trying to encourage a discussion across the witnesses today. So if someone says something that you feel you need to add something to, disagree with, we'll take it if you don't come in that you agree with those comments. I'll move to Dave Torrance for our first question, please.
Thank you, Convener, and good morning, everybody. I represent Kirkcaldy constituency, which has the highest teenage pregnancy rate in Europe. We have education in schools, we have partnership working with Fife Council and NHS Fife. We have drop-in centres, community pharmacies, the third sector like Kirkcaldy Teens, YWCA, YMCA or community halls, all involved in tackling the teenage pregnancy problem. What evidence is there of planned teenage pregnancies and what factors play a part in that?
Maybe start off with that, obviously covering the Fife area, and obviously with the statistics that we've seen for Scotland recently, we have been particularly concerned that Fife has had rates that have been higher than other health boards. In terms of teenage pregnancy as a whole, it does cover quite a spectrum of young people's circumstances, and I think it is certainly the case where some young people will decide that for them what they would look for is a pregnancy at a young age. Now, some of the things behind that involve the self-esteem of the young people. It involves a degree of respect afforded within their relationships, within their community. It may reflect a lack of aspiration of job opportunities. And it really illustrates the fact that this is really quite a complex area to unpick, because we know for many young people it may be a case that they didn't think it would happen to them and it's not in any way intended or planned. But we certainly have come across young people who have said, that is what I want. And when we're aware of that, we can then work with the young people, with the services locally on the ground, to look at what the needs of these young people are and to understand their situation and to understand how perhaps to explain to them that there might be a lot of wider considerations to think about before planning a pregnancy, such as the circumstances into which the child will be born. Is it a stable relationship? Can they build a stable home for a family? And are they mature enough to cope with that circumstance? So I mean, I think that brings out a number of the complexities within this whole area, and I'm sure my colleagues would be able to expand upon that.
Certainly very much agree with the complexity of the issues. I'm from Tayside, and obviously Dundee has historically had some of the very highest rates of teenage pregnancy, and what that prompted us to do was to carry out some local research to get a much better understanding of the circumstances of young women and whether some of the pregnancies were in fact planned, unplanned, or the extent to which they were unplanned, and how ambivalent young women were about being pregnant or not. And some of the things that emerged from that research, which was carried out fairly recently, was in 2011, from those young women who had said that they had wanted to be pregnant, they wanted a baby, was very much around looking for love, looking for affection, looking for the baby to someone that they could love unconditionally, and that would love them in return. There was also something around gaining a recognition and status within families, within their communities, where for some of the young women they might not see that in terms of their own educational attainment or indeed in terms of employment. So having a baby was almost like being recognised as moving into to adulthood. Another factor that did come up, and certainly from the wider evidence comes through as one of the strongest predictors of whether or not you'll be a young mum, is whether or not your mum had you when you were young. So sort of following those patterns within communities and families was also something that came out. And then lastly, the theme that seemed to emerge was that certainly for some of the young women, they were looking to move into. There was a hope that they would be able to get their own accommodation, to be able to move out of the family home. Now that was quite interesting, because that was often and had been raised for a number of years, and certainly wasn't a factor that professionals felt was an influence, but that was something that the young women themselves raised. So it clearly is a perception that they had.
Anyone else?
I think your initial question was to what extent teenage pregnancies were unplanned, and I guess just to add on to that, I think although those are really core issues which have been really well articulated, I think our sense really from the research evidence base, and particularly also looking at the abortion rate in teenagers, is that most teenage pregnancies are, however, unplanned, although those are very much the issues for those that are planned with those caveats. Our sense is that in Scotland most teenage pregnancies are unplanned.
And very much to echo what Nicky said, that was certainly borne out in the local research in Dundee, that the vast majority of teenage pregnancies were unplanned, but the factors influencing decision making almost were quite different in the group that of young women who expressed a desire to have a baby.
Anyone else wish to add to that response? Yes, go on.
Sometimes as well, that's why we use terminology around unintended, because unplanned indicates some real sort of sense of, this is what I want to do, these are the reasons why, and while a baby or a pregnancy may not be intended, it may nor be unintended, and that's it links to some of the complexities around fatalism, and again linking back to these issues around aspiration in education and giving young people, young women and young people, a reason to delay parenthood. So I think it's helpful to think sometimes of unintended rather than planned or unplanned.
So I don't get a sense that that research told you much that you didn't already know, maybe other than the driver of setting up a accommodation. But when the strategy was outlined and targets set, I think that would have been a similar understanding of, so what has happened or not happened in that period of time that has resulted in those targets not being met, and the lack of progress on this, which I think brought the committee's attention and this inquiry.
From the government perspective, it's right that we didn't meet that target that we'd set, but we missed it by, I think, 0.3%. And while this is still a challenging area, I think it's important to recognise that there has been some signs of progress. And if we look at the ISD statistics, the official statistics that are produced annually, the rates of teenage pregnancy in under 18s and under 20s have gone down consistently over the last 4 or 5 years. And I think now we're actually certainly at the lowest level we've been since 1994. And now that's not a reason for complacency. We still need to do work, but there are signs of progress. And I think that reflects the fact that we did launch the first Scottish full strategy on sexual health and teenage pregnancy back in 2005, and we've kept up that momentum. We've maintained funding, we've maintained messages to our local partners about the importance of education in schools and access to sexual health clinics. So there has been consistent investment in terms of resources and activity, and we are starting to see a downward trend. That's not to say we've solved the problem. I would hate to leave people with the impression that there's been no progress, because I think there has been some progress, certainly.
Yes?
The reason we commissioned that local research was essentially because at that stage the data from ISD was suggesting that rates of teenage pregnancy in Dundee were double the rate nationally, and I think it was really important for us to understand whether the factors that we know from the international and national evidence were at play in Dundee, or whether there was something more significant than that. So the research did confirm that Dundee actually wasn't particularly different, although there are probably stronger factors in terms of social and community norms around early parenthood. But very much in terms of the work that's happening and on the basis of the national strategy, there's been a very significant amount of work happening locally, and I can certainly say from local data in Tayside and in Dundee in particular, in the last 5 years to the end of 2012, we've seen a 50% reduction in all teenage conceptions within Dundee. So absolutely it's not for us to be complacent, but I think it would be wrong to arrive at the conclusion that there's been no progress made, and that may well be the case in other parts of Scotland where we've got more up-to-date data.
May have been me again. I didn't, if there was no implication in my question, I don't think that no progress is made. I think the committee understands that progress has been made, in the 1820s. I think we would like to have a practical understanding of not about how that is delivered on the ground, but we also want to know why there hasn't been, according to the figures that we have, little or no progress in the younger age groups. And when we get further into it, I'm sure others are, the variations that take place across Scotland and how we can tackle them. But, why the decline, practical decline in that age group? Do we need to shift our priorities, and why the lack of progress on the younger age groups?
A couple of observations I would make on the under-16s, and others more knowledgeable than I might be able to offer more. The under-16s has been consistent. It's sort of fluctuated around the same sort of figure. But when you look at the numbers, they're very small numbers in the Scottish context. You're maybe talking about 600 a year. So if you spread that around the country in terms of local areas, it's very small numbers, quite widely dispersed. That's not to say we can't do something with it, but I think the people who are conceiving at that young age will have particular needs and will be in particular circumstances. And I think when we look at things internationally, I'm not aware that anybody has really cracked that issue about the very young. It's a very difficult issue to get into because in some ways it reflects back to a lot of the stuff you heard in your previous section about intergenerational issues and deprivation and really complex needs. So you're right, it's not significantly improved, but we also have to put it in the context of it being very small numbers and the complexity involved in really tackling those.
Maybe some people, over a parliamentary term, that's about 3,000 babies or something. And you're putting it, in context of what Harry Burns, some of you may have said there yesterday about the challenges of those very young mothers having those children.
Just to pick up on that point, I think something that's often missed is that the ISD figures, when they relate to teenage pregnancies, also include conceptions that go on to termination, so they're not necessarily births.
Is that it? Dr. Watson.
Just coming on the issue of how challenging it is to make progress, and we know that there are some specific areas where the rates may be particularly higher than others. That often goes along with the socioeconomic inequalities, which you've been discussing. There are also cultural factors around this, where we find in some areas it seems to be quite an accepted norm. So, for example, the mother has had a baby when they're young, and then the perception within the environment is that, well, I did it, so it's okay. And I think what we have to realise is that if people are accepting this as okay, we're not going to change it. So we have to challenge some of the cultural norms about this, and perhaps some of the acceptance. So that leads very much into working with the parents and the carers in supporting them in having the right kind of conversations with young people at the right kind of age. And obviously not everybody feels capable and competent to do that. So I think one of the very important things is supporting people within their environment. That should include the parents, the carers, obviously the schools, youth work, so that young people have positive activities, positive aspirations, and feel empowered to make choices about their lives rather than feel that really this is the only norm that there is and this is the accepted way to behave within a specific community. So there are issues around the boundaries and the perceived activities in the environments where young people are growing up. So I suppose it's wider than saying this. It's about sex, or it's about sexual health services. What do we do before the young people get to that point? We need to really look at the context of the relationships and respectful relationships, because you do hear sort of worrying sort of stories from some communities where the respect between the girls and the boys is not there, or there's sort of worrying access to pornography or social media, or use of sort of electronic devices, people not perceiving boundaries, which some people might feel are in some way old-fashioned. But there is something about the values that we're transmitting to young people, and that this may be a small minority of young people, but we need to think very carefully about how we get in, how we are in the situation, and how we can tackle some of these cultural issues.
Is anyone else?
I would agree with what Lorna's saying, and we know that from the talking perspective, there's really good evidence around that. And not only is that about talking about, you know, sex and sexual relationships, but actually having that relationship between a parent and a child, or a carer and a child, from a very young age, and just about talking generally. And evidence from the Healthy Respect demonstration project did show that if you have this connectedness between a parent and a carer, or a young person, then those sorts of conversations will help set up those boundaries, and those sorts of conversations, and those sorts of those areas that can help support a young person maybe delay a sexual relationship, and to be stronger and have those relationships based on mutual respect and so on, that can really help them in terms of delaying parenthood.
In terms of some of those attitudes that you were talking about within some communities where there's a more positive, or there's a more enabling attitude towards childbirth in the teenage years, I think there's a job to do with a range of workers, youth workers, the practitioners that young people are with on the ground, to skill workers up, to be able to frame a different set of options for them in a way that doesn't come across as judgmental. And I think sometimes it's the risk that they might come across as judgmental that might be a barrier for some staff in doing that. So it should be framed in a way that's about wanting better for the young person. I want better for you. I want you to want better for yourself. So I guess tying into that aspiration thing that you were talking about.
Yeah, I'm going to bring in Mark MacDonald, but you know, again, that respect issue was, you know, understood when we developed the strategy. A number of years on, that hasn't been successful in terms of outcome for that group. You know, I think the committee are looking for, you know, some ideas and some of your experience that may influence our recommendations. What, you know, what have you learned from that? From that, I'm going to bring in Mark MacDonald, but you'll get an opportunity to later. Mark.
Sure. I think the way the discussion is evolving, I mean, the way I come at this, I think there's a double-edged sword here, and that is that obviously we want to reduce instances of underage pregnancy. I take the view that when there are instances where people are over the age of sexual consent, where they may be in stable relationships, that a pregnancy will occur. There are obviously going to be instances in those age groups where unplanned pregnancy is going to occur. My focus is more on those under the age of 16 who are obviously at much more risk of social issues as a result of a pregnancy, be it planned or unplanned. And I guess the difficulty is that if we create if there is a stigma around that, there is more likelihood that those individuals will disengage from services, or they'll disengage from social groups. So I guess the question I would ask is, you know, if we accept that no matter how much success we have in the message, there are still going to be young people out there having sex, how do we ensure that that does not then translate into unplanned teenage pregnancy? Secondly, where a teenage pregnancy is occurring, whether it's planned or unplanned, how do we ensure that the appropriate support is there for that individual? I mean, if I think to when, you know, I was 28 when we had our first child, and it was a terrifying experience. I can't begin to imagine what it would have been like if we'd been half the age. I cannot begin to imagine that. You know, how do we ensure that these people get appropriate access to antenatal support, for example, where they might be finding themselves alone in a room with people in their 30s, couples in their 30s who are having children? How do we ensure that the stigma that is attached to it doesn't lead to these people disengaging, while at the same time doing all that we can to prevent teenage pregnancy from occurring? I think it's a very difficult balancing act, but I'd be interested in the views of the witnesses in that respect.
To respond to a couple of your points, there's a few things that certainly we've promoted and we've pushed since Respect and Responsibility, which is about, if young people are having sex, how do we make sure that doesn't turn into a pregnancy? And so obviously we make sure that there's good quality sexual health services available to all young people at or near schools. We have good access to condoms and contraceptives, which can mean that people who are in that situation can use contraceptions if they need to. In terms of when people do end up pregnant, what sort of support can they get? You're absolutely right. It's important that, particularly if they're younger, they get support. And one of the things that's, I think, a relatively recent introduction, and which might bring a lot to this, is the Family Nurse Partnership, which is working with particularly vulnerable young people. And I think there's evidence around, when you're working with young people, the Family Nurse Partnership may be able to increase the time between subsequent pregnancies, so you can have a real impact on the young person's life. And people may know more than I do, but that's one of the things where you can see quite tailored and quite intensive support given to the young people who would need it most.
We've also done good work around, as Gareth said, with the high quality services, and also the provision of longer acting reversible contraception, which is things like, particularly for your young woman, would be your implants, and that gives them your opportunity to provide contraception that lasts for around 3 years. So that if they're using that sort of contraception, that in terms of unintended pregnancy, it doesn't protect against STIs, but in terms of unintended pregnancy, they are protected. So that's another one of the things that we've been working on in terms of helping young people prevent an unintended pregnancy.
To return to your question around gaining a practical understanding of what we need to be delivering and how we deliver that on the ground, and I think we started by explaining some of the complexity around the factors influencing teenage pregnancy, and it's quite important that we also then acknowledge that there's no one single thing we should be doing. It's about a range of different interventions that need to be in place, and at the scale that they're needed to influence change. But absolutely support what people have said about young people making informed decisions and the importance of consistent and high standard sex and relationships education that builds skills and communication and confidence of young people, and the ability of young people to access sexual health services, and in particular contraception and the more effective contraception, undoubtedly I think will have had an impact on reducing teenage pregnancy. But it's about coupling those things with the interventions in the earliest years of childhood, which Harry Burns was talking about in terms of the early years collaborative in the earlier part of your session, the intensive support that is provided through programmes like the Family Nurse Partnership, which right from the beginning begin to build resilience and aspiration of young people that are really important, coupled with the work that we're doing with adolescents and pre-adolescent young people around building their own aspirations, expectations for themselves, self-efficacy. Now that the evidence that seems to be encouraging around that is about the sort of experiences that young people have. So not necessarily about being told things, but actually having the opportunity to volunteer, to buddy, to be peer educators, to get involved in their own communities. That in itself is a protective thing, not just around teenage pregnancy, but about a lot of the outcomes that we're trying to improve for children and young people. And it's coupled with that and having the competent workforce that I think Nicky alluded to earlier. That's youth workers, that's teachers that are really confident to deliver meaningful, relevant education in our schoolrooms and way beyond in the school context, and very much a sort of strong partnership from local authorities, from the health service, from the third sector, and a real commitment to how we work together to tackle these issues, but based upon the evidence. And I think most importantly, perhaps, is also about how we work with communities. So instead of, again, what Harry was talking about asset-based approach, it's not doing things to people, but working alongside communities, and particularly working alongside young people to identify and share the evidence that we have as professionals with communities, but work with communities to share their own experiences and look at developing shared solutions that actually are more meaningful in their own lives and in their own communities. And that's certainly something we've been doing in the last 2 or 3 years in Tayside, in some of the communities where we have the highest rates of teenage pregnancy. And the response to that has been very, very heartening. It's been much, much better than we expected. And the innovative response to that from young people and from people in the community generally has been tremendous, and certainly much greater than we could have expected, that's resulting in changes in the way that we will deliver sex and relationships education within the classroom, for instance, where we've got peer educators wanting to go out and work within communities. So I think it's about how we work with communities and very much focusing this on improving outcomes for children and young people. And I think when we were discussing things as in the coffee room, as you do, one of the things that I think we all felt was important to get across is this. It's very much been focused around sex and sexual health services. And I think most of us feel very much that this is something that needs to be, the focus for teenage pregnancy should be, and the responsibility for that should be much broader, because it's about how you have the leverage to change the life circumstances of young people. And that's where it's really welcome to see in the framework the shift in leadership around teenage pregnancy to local authorities, because they have that greater degree of influence.
Nicky, and then Dr. Watson. No, we've got one first and then you.
Okay. I guess I just wanted to pick up on some of that about the differential contributions to addressing teenage pregnancy that various partners can make. And you were talking there, Anne, about sexual health. And I guess Scotland's been on a journey in the last 10 years. We've had the Respect and Responsibility strategy very much focused on making sure that we had, across Scotland, good quality sexual health and relationships education in schools. And also hopefully reinforced by parents as well, and sexual health services. And Scotland needed to do that because we weren't in that position 10 years ago, and the strategy very much enabled that work to happen. And it's really interesting that simultaneously with that there was also the additional financial allocation that was given out to local authorities through Learning and Teaching Scotland to enable teacher training. And there's a range of issues that all happened around 2005, 2006. And you then start to see the downward trend in teenage pregnancy rates in Scotland kicking in. And I don't think that's an accident. So where we now are, I think, is, as you were saying, Anne, it's about moving to, we need to keep that foundation, that really solid foundation that we've built in sexual health. We can't let that go. We've got to keep that in place. But it is that wider work that we now need to do. So, and at the risk of repeating what everybody else has said, so the early years work, that work around teenage transitions, where you have what shows up in the research evidence as youth development approaches, that very much taking the talents and natural interests that young people have and getting them to apply those perhaps in a voluntary capacity or whatever. And particularly, I think the challenge for us next is to look at this in smaller neighbourhoods. We look at things on an NHS board basis, and we've looked at them on a local authority basis. And actually, we need to be now underneath those figures and looking at smaller neighbourhoods where the rates are particularly high, and actually doing some very focused work, because in every area, I guarantee you, there will be workers who, if you said to them, these are the indicators that would tell you that a young person might be at risk of a teenage pregnancy, I can guarantee you the workers could tell you who they were. So what we then need to do is actually skill those workers up to put in place the right interventions.
Dr. Watts.
Okay, we're just going to come back to the issue of stigma that you'd mentioned, and the fact that the concern that young people might be put off accessing services or antenatal services. So I think that's something that we're quite aware of, and obviously the young people who give birth and become parents, that has to be seen as a positive event, and one in which they will be supported to parent their child and have that child grow up and have a positive future. So we're very aware of the need to support the young people who come through in this situation. With respect of the antenatal services, as we've heard, the Family Nurse Partnership has come in for teenage parents, and that is great. Predating that, however, our vulnerable young people, so that in the under 16 group, certainly would be identified by the midwifery staff, and would generally have some form of enhanced antenatal care, where there's more of one-to-one support that is looking more broadly at the aspects of vulnerability in that young person's life. It may be that if they are offered antenatal classes, it might be with other young people in similar circumstances, and as you say, it may well not work to be in with sort of a bunch of people in their 30s if that was the case. And there has to be a targeted approach through the antenatal services and the antenatal inequalities framework as well. So we're very conscious that there are different needs of people who are pregnant, and the under 16s would definitely be part of that. I mean, some of the coexistent issues may be domestic abuse, substance or alcohol misuse, learning disability or borderline learning disability. So it's not always just age that's an issue. You have to look at the circumstances of the young people, or indeed the people at any age requiring maternity care. So we do need to look very carefully at that level of support. That ties into other inquiries, such as the confidential inquiry into maternal deaths, where we know that vulnerable young people, or those in complex social circumstances, are the ones more likely to have adverse outcomes. So I think in terms of our antenatal services and the services for support, both antenatally and postnatally, that will be very much enhanced by the family nurse partnership. But we certainly have had in place, predating that, very much enhanced support around vulnerabilities of people in this circumstance. And just one point as well about on the preventive side, the services for young people are accessible drop-in services for young people are very important, but they're not usually just about sexual health. Young people can go to these for smoking or mental health issues or other concerns. So in most cases, where there's a drop-in or where there's, say, a school nurse offering advice, it isn't solely about sexual health, and great efforts are made so that they're accessible, that they're confidential, and that young people can go to these without feeling that there's stigma attached as far as possible. And the engagement with young people has to happen to ensure that those services are meeting the needs of the young people themselves and the perceptions of the young people.
It was just, I suppose I could pick up a little bit on what Lorna was saying in terms of thinking about the next steps beyond pregnancy almost. We do have difficulty with what do you do with a young person under the age of 16, for example, who's had a baby. Parents don't quite, the child's parents don't quite know what to do, how to normalise that. The school certainly doesn't know what to do and how to normalise that and how to get these children back into education, because we know that their outcome is going to be so much better if they are able to return to education and to look at a more positive prospect. So that's kind of one thing, picking up on what Lorna was saying. The other bit is that sexual health isn't in isolation. Sexual health has to be viewed alongside other risk-taking behaviours, for example, as Lorna mentioned, in terms of alcohol, in terms of experimentation with drugs, in terms of pushing the boundaries. And we know that one of those elements is about how parents respond to that and how they manage their children and how the rest of society manages those children as well. So I think we need to make sure that we have those links made with other agencies that are addressing alcohol and drugs, for example. So in our area, we have a strong link between sexual health and the alcohol and drug partnerships to try and move things forward. I'm conscious that certainly in Ayrshire and Arran, we have quite high levels of under 16 pregnancy. We have a strong deprivation gradient, which is another element that we're trying very hard to consider. And our concern is that socioeconomic circumstances are such that that may well get worse before it gets better. So it's just trying to identify that this isn't just an issue for sexual health, this isn't just an issue for the health service, and there is a strong issue of trying to engage partners and trying to work with partners who perhaps don't want to be engaged for a variety of reasons. And that's something that certainly in Ayrshire we still have issues to overcome.
Bob Doris.
I should point out, Dr. Watts, we should make clear that I didn't set you up for my next question, which links in quite well to what I was going to ask. That was unintended. Anne Eriksen had mentioned one of the links between prevalence of teenage pregnancies was whether your mother had a child at a young age themselves. So on that basis, I would imagine the support you give very young mums having their first child will determine the likelihood of how their children will be 13, 14 years down the line. So we always have to be looking at the medium to long term. The committee visited Smithycroft Secondary School in Glasgow yesterday, where young mums from across the city, whilst supported to stay in their own secondary schools if they wish, have the option to have their education at Smithycroft, but very much also wider support, wider societal support, and linking with a variety of age groups. There's initial evidence to suggest that, having spoken to some individuals involved in some of the projects there, that the likelihood of multiple births from these young mothers to go into a second and third child is likely to be reduced, which will give a positive outcome for them. And we would hope that in a number of years' time that those young mothers would have formed a positive relationship. Well, they are. We met them yesterday. They were fantastic. They're forming wonderful relationships with their children, and the likelihood of their children flourishing and not having unplanned teenage pregnancies is likely to be higher. So is that, I see from the nodding head, you're likely to say, yes, that is the kind of project we need, but I suppose more importantly to the committee then, rather than just affirming that this is a good thing, is what's the prevalence of that kind of quality support across the country, and how do we make sure we reach all parts of the country where that is clearly needed?
I think it's not that common. I think city areas find it easier to do than more rural areas. But the other element is really that we need to make sure it isn't a project, that it is sustained. And I think that's really, whatever we do has to be something that can continue, that is not just a one-off, we'll try this, and if it works well, it might work, and if it does, then we'll think about whether some money goes into it, and if we don't put money into it, we'll try something else. So it is a matter of having a service that we can continue to provide. And I think that kind of sustainable service, I would imagine, is what they're trying to build into education, and that's what we would encourage. So we do have that control in terms of secondary preventions, making sure that we have good family spacing and making sure that you're able to provide sufficient support, and that the community can provide sufficient support for each individual child.
Any other comments? Yes?
Certainly in Fife we have a Young Mothers Initiative, and we have a specific worker who supports those who are still in education to remain in education and to stay engaged. And that does bring in quite a wide range of supportive elements. Where there might be more concerns are the ones who have left school or disengaged with school, where it's a little bit harder then to have the setting in which to put all those supports in place. So obviously if the conception happens just before they're 16, quite often the young person may leave school. The school then isn't aware that the pregnancy has occurred at all, and may come back when they see the statistics and say, but you know, out of our school we're only aware of 1 or 2, when in fact the numbers are greater than that, but the school's perhaps not aware. So where you have the educational setting, the support can be easier to coordinate when people are still in education.
From a government perspective, we're always interested in anything that works, and we're always interested in the evidence. And the sort of project you're talking about sounds like a really good project. And certainly what we've tried to do under the framework, which we published in 2011, is move away from trying to tell local authorities and NHS boards exactly what to do, but tell them or guide them what we want to achieve. And I think we have to, not necessarily this doesn't work all the time, but we should try and avoid taking something that works in one area and plugging it into somewhere else. I think the local authorities, the NHS, the communities, has been mentioned, need to decide what works locally and investigate what works locally. So we tried very much to make the funding that supports the sexual health and BBV framework flexible, and to make the outcomes high level, to allow people locally to innovate. It's almost liberating to innovate, give them the opportunity to find out what works. And if these sort of things are now percolating through, that there's projects that work, then we want to learn from that and see if it can work elsewhere. But it doesn't automatically work. There's something that works in one area, whether that's because it's urban and other areas are rural, will work. But I'm sure there will always be things that we can learn from these projects.
Yes.
I guess one thing I would like to say about that is about the issue of funding a resource like that. That was a very hard won service to deliver in Glasgow, and I suppose it's about how that's funded. It's not funded directly through sexual health monies, and it's quite difficult, I think, politically to achieve funding for a service like that, because teenage pregnancy is seen, particularly I think at a local authority level, as sexual health business. And so trying to contextualise it beyond sexual health to attract funding for a service like that can be really challenging. I think it really illustrates my belief, which is that, you know, local authorities do have they really have the central role around addressing teenage pregnancy, and I think going forward it'd be really useful to have for local authorities much clearer guidance, much clearer direction, I guess, around what that means for them in terms of their community planning structures, what it means in terms of their children's services structures, around the stuff that isn't necessarily sexual health, but is just around some of those wider sets of issues. And although it's clear in the framework that local authorities are the lead for teenage pregnancy, I think if I was, well, it's my experience working with colleagues in local authorities that when you're faced with that, your next question is, okay, what next? And I think you've already heard what a complex issue teenage pregnancy is. So making sense of that and turning that into very practical, tangible action is challenging. And so I think there's a place for some clearer guidance for local authorities and particularly community planning partnerships around their respective contributions to this agenda.
It's quite interesting having the earlier session and come right on to this session. It's the council job, you know. But that interaction of services is something that we've picked up in the last couple of days. Those of us had the benefit of doing the visit to Smithy, Croft, and the earlier evidence session, and now, and you know, as maybe it would be interesting just to develop that a wee bit in terms of the shared information that you mentioned earlier, that in some cases you may not be aware of those teenage pregnancies. We picked up some of that in terms of midwifery services and how they connect. Education, of course, obviously, and while it's been suggested earlier that we need a strong and wide range of quality interventions, you know, the question of access, you know, and I suggest maybe this is a job for the Scottish Government, that at least you should be identifying where best practice is, and you know, it's. That local autonomy in this area is a virtue. We've heard what we've heard, but is there in your networks, the evidence that access to services are good and available right across the board? Do the people who are involved, education, midwifery services, health service, are they working together effectively to create the interventions that we want? What are the barriers to yourselves doing a better job in delivering here? With the Scottish Government official and the committee, let's let them take some messages back.
I think it depends on what level we're starting out at, whether we're saying this is about primary prevention or whether we're saying this is about once we've identified a young person who has fallen pregnant. So we can kind of split it up into those different levels. If it's about the primary prevention work, then it's quite difficult to demonstrate that we have an issue that needs to be addressed collaboratively. And I think that's with the small numbers and the high variability if we're talking about the under-16s. So I think the actions that we've taken around things like family nurse partnership and around starting to move in some of the asset-based approaches is starting to develop momentum and starting to build success. But we're also aware that young people, particularly the under-16s, are much more likely to conceal a pregnancy and present late. So they might not even realise they're pregnant until they start to go into labour. So there are elements associated with, whilst we would love to encourage early access, early antenatal care, that's not practicable for a chunk of these children who don't identify that this is an issue they need to deal with, or who have other issues in terms of the family disruption that they've got, in terms of the relationship they have with their boyfriend or not, in terms of what other substances they're using, those kind of elements that come into play as well.
Complex.
I think if it was simple, we'd have solved it.
Yeah, we're getting that message this morning. It's really difficult, all of these problems. I think that's why we're having an inquiry.
Just wanted to say that whilst, and I think I said earlier that welcome the transition in the leadership role to the local authorities. What's, I think, extremely important is that this has always been a partnership. It's a partnership of local authorities, health, the voluntary sector and the communities themselves, and that will always remain the case. And health has a fundamental role, not just in terms of some of the delivery of services, but also in making sure that we share the evidence in terms of what works and some of the epidemiological data that we hold. Speaking from a local perspective in Tayside, I have to say that we've worked very hard, and I think you're coming to Dundee next week to take evidence. We have really strong and good partnerships within community planning in all three of the council areas, and that's no different in terms of sexual health or teenage pregnancy. But we invested quite a lot of time in setting out why teenage pregnancy actually mattered, why it was relevant. And it was quite important in doing that not just to concentrate on the under-16s, which, as a number of people have said, is quite a small number, and it can seem quite a marginal issue to council colleagues who are dealing with issues that affect much larger populations. So a lot of time investing in why it matters, why it's relevant, and what we can all do together to make a difference, and embedding that in the work around GIRFEC and the early years framework has been really important. It's also about getting the buy-in and strategic leadership at the right levels within councils is pretty crucial. Having the ear of the Chief Executive and the Director of Education and the Director of Social Work is really vital, because they're the people that can actually make some of this happen at a local level.
You asked to what extent are those sort of partnerships working across the country. What we do every year, we go out under the Sexual Health and PVP framework, and we visit every NHS board at least once a year, and we just finished a series of those visits at the tail end of last year, and we use that as an opportunity. In fact, we invite local authorities and other partners along as well, so it's not just an NHS board visit, and we use that to probe just these sort of issues right across the framework. How well are things working? And it's true that things are working better in other areas than in some other areas. And so what we have to do then is we have to bring that back in, and then we have a role to facilitate the different parts of the country learning from each other. So obviously things work very well in Tayside in terms of the relationships between the board and the local authority, and we can try and export that to other parts of the country. And we have very good networks with all the executive leads who meet very regularly, who can share that sort of experience. But it is a challenge, and it's a challenge because I understand that local authorities think teenage pregnancy, that's a health issue. But from my perspective, a lot of the things that will contribute to reducing teenage pregnancies are things that local authorities are doing anyway and should be doing. But if you put a teenage pregnancy badge on it, then they get a bit nervous. But it's actually about deprivation, it's about aspirations, but all the things that local authorities do and do well. And it's just about having that sort of conversation with them at the right sort of level. And that can be difficult.
It would seem that the variance might come down to some of the political skills. I mean, you've described there the process that you've got to go through to get buy-in from a local authority. You've got to have a good relationship, win the argument with the chief executive. I mean, it's hardly free-flowing. This, if you've, that can be down to the skills of individual people. Richard, I'm sorry.
I think partnership thing's obviously very, very important. I just want to check that. If you look at child protection, that the Mars and Child Protection Network's been merged into WITH Scotland, which is an academic unit which actually draws together research, draws together best practice, and then helps to channel that back out. So if you like, it's a sort of organised, centralised unit that supports the progress in that particular field. Do we have the same thing in the sexual health field? Because it's not dissimilar, except that, as you've said, the problem is it's seen more as a health issue and not as a social work issue, whereas with Mars and child protection was very much a social work thing, and actually there's quite a lot of health involved, and getting the health engaged is important. So I suppose my question is, have we got a good analysis and sending out of research evidence? Do we do toolkits in the same way that with Scotland does? How are we rewarding success if a project does work in a particular area and, as Nicky's been saying, achieved against funding difficulties and all the rest? How do we then reward that? Is that a central function, or do we just leave it to the local authority to continue to battle away? Do we actually say, that's great, we'll now put 20%, 30% funding into that because it's working, and send a signal to everybody else, there's a project you need to follow? So how do we do all of that?
There's a lot in that. In terms of whether or not we have a formal hub such as what you described, there isn't, that I'm aware of certainly, but there is very good research activity going on both within Scotland and across the UK that I think we have good links with good academics and respected academics that we can draw from, and we can share that. And we have across Scotland, in terms of the networks, we have regular meetings with all the people, and we can share that very well. There are toolkits. We have the Reducing Teenage Pregnancy toolkit, but I sense what you're getting at is whether or not there's some concentrated hub where all this activity can take place and it can consider things and consider what's worked in particular areas, and perhaps we need to formalise that a bit more, where we've relied on networks and having the conversations, and we are still developing the framework. The framework was just launched in 2011. We've only just finished those first series of visits, and maybe we need to learn about how we take that evidence more formally into some sort of mechanism to evangelise around what works, and certainly we're happy to look at that if that's a recommendation the Parliament comes up with.
Anyone else? Respond to Richard? No, we're satisfied with that response. Any other committee members want to ask a question at this point? Well, I'm going to ask the witnesses that are with us in the panel today, if there were, we had a pre-meeting and you had a coffee meeting, but it is important, and we appreciate you coming along here. And there may have been issues that you felt that you wanted to put on the record here today, that you want to take that opportunity to do that now, and I'll take your comments. But indeed, any issues that you felt that weren't covered, they were happy to hear further representation from you in terms of email or letters, and we would encourage you to follow our inquiry, and we would appreciate your observations on maybe other evidence that's given in that inquiry, be given your specialist interest. But I'll give you, the opportunity to put on the record anything you feel that we haven't covered that you would want to put on the record now. Okay.
I think you've covered pretty much everything that I would have wanted to say. Right. I guess I would summarise it as this is not just a sexual health issue, it's about deprivation. There is no magic bullet. We need complex, multifaceted interventions to deal with it, and that does have to happen in a partnership way. And I would welcome the outcome of this being about clearer guidance to various sets of stakeholders across various sectors around what that looks like.
Any other comments at this point? Anne?
I think very much support what Nicky's just said, but returning to the issue we just left with is that I think it would be helpful to think about research in the Scottish context about what works, and think about how we're actually not just capturing what appears to be working at local level and disseminating that perhaps better than we have done. And that is something that I think lead executives have been looking at in terms of the framework more broadly quite recently. But the understanding of our population needs, I think, is pretty crucial. So it's the research side of things and supporting nationally some of the quality evaluation that would be needed to support that.
Okay. Don't feel the pressure. I mean, if you haven't got it, Dr. Watson.
Just one of the groups at risk, which I don't think we've mentioned, is looked after children. So that's one area where we've been very keen to engage with social work colleagues and carers. And some of the barriers, for example, we set up a training session for foster carers at a time when they said would suit them, in a place that we said would suit them, and then I think one person turned up who was already quite clued into this area. So it's something about the level of engagement and the understanding of which groups are at risk and who are the key people in relation to those young people, to be giving consistent messages, and also the involvement and training of social workers who are in contact with a lot of the vulnerable young people who may be at higher risk. And again, we have managed to train social workers, but then another year you go back and they're too short-staffed, or there's too many pressures for them to take that on. So these are the kinds of issues that you do come across. And I think it's also helpful to say this relates to a few years ago discussing with a head teacher about the delivery of education and the importance of this as an issue. And it's a very, very interesting discussion, saying, well, the young people have got no job prospects here in the community. There's a lack of good male role models, and there's a lack of positive alternatives. And from his point of view, there were other things to be dealt with, and he perhaps wasn't seeing as strongly as we did the place of really good quality sex and relationships education, particularly because of those circumstances and because there were vulnerable young people there.
I might
yes.
challenge that to some extent in terms of saying that if we consider teenage pregnancy as a symptom and not as a condition, then that enables us to put it in that wider socio-economic context and allows us to consider it alongside the behaviours of young people in terms of alcohol and drugs. Why do they behave as they do? Is this an intergenerational thing? Is there an epigenetic element, as Harry was talking about? And I've got a different hat in terms of fetal alcohol harm, but in terms of children who are alcohol exposed in pregnancy themselves, we know that they are more likely to A, consume alcohol, and B, be at greater risk for teenage pregnancy. So with another hat, I'm kind of bringing in a different strand. But it's the symptomatology bit for me.
Thank you.
There's just one final comment I wanted to make, which I'm sure everybody in the room understands and agrees with, but I think it's useful to make it, in that despite all we've said about teenage pregnancy, a teenage parent is not necessarily a bad parent, and we always try and do what we can to not stigmatise in these sort of conversations teenage parents in general, and I'm sure everybody in the room understands that. And their efforts to reduce teenage pregnancy is not about stigmatising those who find themselves in that situation.
Is there anyone else? Can I thank you all for your attendance here and your help, and encourage you to observe and continue to participate in our inquiry when you feel it necessary. Thank you very much. Thank you. Thank you. Can we now move on to agenda item number 3, which is health inequalities inquiry and in regard to witness expenses. The item is to ask the committee to delegate authority to me as a convener to arrange for the SPCB to pay under Rule 12.4.3 any expenses or witnesses to the inquiries. Can I have the committee's agreement? Agreed. Thank you. The agenda item number 4 is again to ask the committee to delegate authority to me as convener to arrange for the SPCB to pay under Rule 12.4.3 any expenses of witnesses, this time in respect to teenage pregnancy inquiry. Can I have the committee's agreement on that? Thank you. We now move to agenda item number 5. Our final item today is to consider the committee's approach to petition PE 1451, Belinda Cunningson. Members will have read the paper and prepared by the clerks. And can I invite comments on the members, from the members? Aileen.
Thanks very much, Convener. As committee members will be aware that we've received an extra paper in support of petition PE 1451 by way of a letter from Mr Bill Gibson, who is also a constituent of mine in south of Scotland. Mr Gibson has asked that I present his evidence to the committee this afternoon. Just as some background, Mr Gibson is a founding member of the Freedom to Choose Scotland and chairman of the International Coalition Against Prohibition. He came to visit myself at my regional office in Dumfries on Friday, where he presented 8 years of research by way of 2 DVD discs, which contains audio and video evidence to support claims, as well as substantial written evidence, which I've also brought with me to the committee. This is to do with the health effects of second-hand smoke. And the written evidence certainly sets out a lot of very comprehensive scientific evidence that Mr Gibson has put together, which they believe show that ventilation is improving. And they contend that advances in ventilation and air cleaning technology and existence of a European Indoor Air Quality Standard EN 13779 relating to the ventilation for non-residential buildings, and that this would therefore justify a review of the smoking prohibition and control provisions of the Smoking Health and Social Care Scotland Act 2005.
Thank you. Gil Patterson?
Yeah, a couple of points, Convener. I would like to talk about ventilation, which I've got some experience of, although it's an entirely different industry. It's in the automotive industry. And we engage in a daily basis with hundreds of companies who are involved in protecting their workforce from pollution and from breathing in particulates that would damage their health. And let me say that in my view, there is no ventilation that would protect someone in a workplace from smoke in any shape or form. And if I could give you an example in the workplace that I'm talking about, we're talking about a sealed container that the person is inside. And the only way that you can, with it, the cost of these pieces of apparatus to extract the air is enormous amounts of money that's used to buy them in the first place, but to make them operate efficiently. But the only way that the individual can be protected is actually by providing a full mask. And the mask isn't enough, because you've then got to bring air in to pass over the face so that nothing comes in that can be breathed. I mean, you know, in the automotive industry, they don't spend money for nothing, I can assure you. So that the idea that there is a ventilation system, no question about it, ventilation is improving, and I'm sure it improves every day. But to an extent that in a room, like in a pub or a public place, like a place like this, if somebody was smoking, to get the smoke out, it's got to pass you by. So it then comes on to the other element of it, and that's passive smoking. And I think we're quite clear that, first of all, the ban itself is having a great effect on the public's health in Scotland. That's number one. But particularly passive smoking, how that people are understanding the message that it's not what you do to yourself, it's what you do to others. And so therefore the idea that we would at this stage, in the first place, interrupt a good programme, and I believe this programme should never be interrupted at any stage. I don't think there will come a time when we should lift the smoking ban. I don't think technology will get to the stage that you'll be able to smoke and still protect a person at work. So therefore, in a pub situation where you've got staff, employers need to have a duty of care in the staff, and the idea that we would then, by our actions, listen to this petition and relax at this particular time be entirely wrong. We would be putting work people at risk again. Freedom is freedom to do things for yourself, but not freedom to do something to some other person. So I would not support the continuation in any shape or form of this petition, I'm afraid.
Any other members?
I have to go, Chair, but can I just say I absolutely support Gil Patterson. I think it would be a totally retrograde step to open it. The ventilation debate was held in 2001. It stopped the Act actually coming in earlier when Kenny Gibson and I proposed the first ban back in 1999. The argument was ventilation, and although ventilation has improved, as Gil says, there is no way that without full mask this is going to actually work. Passive smoking will be dangerous. That's what the proof was that led to the Act. I don't see that changing. I think this petition should be closed. I apologise for leaving at this point.
I'm just going to conclude. If there's any other contributions? I think one of the strongest points I think that Gil had mentioned is that while they may argue about the overall impact on smokers or non-smokers, I think there has been a hugely positive impact in the exposure to second-hand smoke amongst bar workers and hospitality industry. There can be no doubt about that. And the first principles, as I knew them in health and safety, it was that you didn't introduce ventilation, you eliminated the hazard. I think the legislation has eliminated the hazard to those workers, is my own opinion. But we have a decision to make. Does anyone, believe it is necessary to take further action on the petition? If not, can I get the committee's agreement that we are recommending that the committee be closed, the petition be closed? Agreed. No dissent. Right. Thank you. That concludes our meeting today. Thank you all for your participation and patience.